Medical College, Kolkata. So after a very well accepted and successful symposium on the fluid and electrolytes, West Bengal Academy of Pediatrics now is going to organize the symposium on another very basic topic, that is ECG and the X-ray of cardiac disorders. So ECG is one of the basic investigations that we do in children with the cardiac disorders, also in ICU, and it could be sometimes life-saving. But it is perceived that the pediatricians are disinclined to these basic investigations, and this phenomenon is quite uncontrolled, and we can overcome this if we approach systematically to this issue. So that's why, so this is endeavor from the West Bengal Academy of Pediatrics to cover this basic topic and learn from the expert on these basic topics. Now I will hand over to our President of West Bengal Academy of Pediatrics, Professor Kalpana Datta Madam, to welcome the faculties and experts and the delegates.
Thank you, Dr. Mee. A very good evening to all, and welcome to this second workshop from the West Bengal Academy of Pediatrics. As Dr. Mihir already explained, we had a very successful workshop. In the first workshop was very successful, and it was well appreciated all over the country, not only in our state also. So we are also encouraged to have this type of series of workshops, and in the coming months also we'll be having throughout the year, which will be related to the clinical practice, not in a very depth and theory, and so that it will help the residents, junior doctors, and the practicing pediatricians for their day-to-day practice in child care. So I'm really happy to see all the faculties, and I'm really happy that Dr. Anita Saxena ma'am, in spite of her busy schedule, she has agreed to join and share her experience. And I think I not only think I'm 100% sure we'll be empowered and will in this by her experiences and deliberations. And I welcome all the faculties and young faculties, budding faculties. I'm really happy to see them to join with the platform. And with these words, without wasting much time, I'll hand over this mic to Dr. Shapan Roy, and wish this a grand success of this workshop for coming 3 days. Enjoy the academic feast. Thank you. Dr. Shapan Roy, please.
Good evening, ma'am. Today, WAP is organizing another workshop, very useful workshop, and it is divided into a 3 days session. And the last session will be accompanied by a quiz. That was very popular last time. And today our speakers will be none other than Professor Anita Saxena, the budding pediatric cardiologists like Dr. Satyaki Das, Dr. Ditabrata Das, the Debabrata Nandi, and Devasri Gangopadhyay. Actually, I am really indebted to all the experts like Dr. Anil Singhi, Dr. Ditabrata Das, and Dr. Devasri Ganguly for formulations of this total workshop of 3 days. I am really thankful to you all. And now I will I am very warm way. I give a warm welcome to Professor Anita Saxena. Actually, we thought that in the busy schedule, whether she will be able to make it or not. And for the participants of this module, you must know that Professor Anita Saxena is now the Vice Chancellor of the B.D. Sharma University of the Health Science and Research at Rohtak. And before that, she was the Dean of Academics, Chief Cardiothoracic Center, and Head of the Department of Cardiology in AIIMS, New Delhi. And she has over 330 papers which are published in the International National Journal with a citation of 6,700. So the enormous job, and she is of international repute, and she is a fellow of American College of Cardiology. So, madam, we are really grateful to you for accepting our invitations. So now I will invite you to give your introductory talk and a guest lecture about the importance of the ECG and X-ray in the bedside clinic. Is it losing its glory in the present era? So over to you, Professor Saxena.
Thank you very much. I would first like to place on record my gratitude to the West Bengal Pediatric Society, which has decided to invite me from Rohtak, from Haryana. And I'm specifically, I would like to thank the organizers of this workshop and my student, who is, of course, amongst you now, Dr. Lopamudra. Very, very thankful to all of you. And I'm very happy to learn that you've had a successful workshop, and I can see a huge attendance even as of now for this particular workshop. And I'm very glad that you kept ECG and X-ray as a topic, because ECG has somehow been considered as a weak point of pediatric training. And when we started pediatric cardiology DM at Institute, I think one difference that I found from DM adult cardiology was their basic knowledge of ECG. And I know that pediatricians are far more dedicated than our internal medicine people, but I think if they add ECG and X-ray to their armamentarium during training, it probably put them well above anybody else. So with that background, I would like to start sharing my screen and try and convince you that ECG has not really lost its glory in the present era as well. I hope my slides are visible.
Yes, ma'am.
Yes.
All right. So, bedside clinic starts with stethoscope. And I know that couple of decades ago, we were saying when the ultrasound came that there is an obituary of the stethoscope, but we all know that we cannot work, we cannot survive without stethoscope, especially in pediatric age group, because auscultation is very, very important, stays very, very important as of today. So after this came X-ray and ECG, and we were very happy that most of the heart diseases we could diagnose on this tripod of clinical examination, X-ray and ECG. And then we know that in early 70s and late 60s came ultrasound, and we were all very, very happy that now we have a tool with us which can actually look inside the heart and diagnose all the conditions. However, it was bulky, it was not available everywhere, it was only present in big hospitals. And then came this marvelous laptop kind of an ultrasound machine, which you could just carry in your bag and carry it anywhere, wherever you want, whether you are going to ICU or you are going to CCU. I know with PCPNDT Act, this portability of the ultrasound has become an issue, but still we feel very comfortable in our clinics and in our ICUs having this ultrasound machine. So with ultrasound, we all have a magical wand in our hand, and we feel very happy that, you see chambers, you see valves, you see septae, you can make any diagnosis that you feel like, you can look for mitral regurgitation, tricuspid regurgitation, anything, whatever you want. So why bother about X-ray chest and ECG? And I think what I'm here today going to do is to try and convince you that X-ray and ECGs are still very, very important. And you cannot do justification to ultrasound and echocardiography if you haven't done an X-ray and ECG in a child before. So since I being a pediatric cardiologist, most of my cases will be from cardiac patients or cardiac diseases in children, primarily congenital heart disease. Now, let me start with this 4-year-old boy who has been having seizures for the last 2 years. He's on anti-epileptics. He's been visiting various hospitals. He's undergone very sophisticated investigations like CT head, MRI, echocardiography as well, all reported as normal. And one of the enthusiastic pediatricians thought that his pulse is a bit slow. For a 4-year-old, 60, 64 is a bit slow. So why not get an ECG done? And here is the diagnosis, right, staring at us, which has been missed for all these years. This child of 4 years had complete heart block. As you can see that there are P waves coming at completely independent of the QRS complexes. There is no fixed PR interval. So there's a P here, there is a P here. Similarly, there's a P here, there is a P here, and the QRS is running independently. So we have a slow rate, we have a definite regular RR interval, and we have regular PP interval, but there is no relationship between the P wave and the QRS. And what all he needed was just a permanent pacemaker implantation, and all his so-called seizures were actually happening because of Stokes-Adams attack, which were being considered as seizures by the doctors. This is another younger child, 6 months old baby presenting in heart failure. Echocardiography done at 3 months of age was diagnosed to have very severe LV dysfunction as myocarditis, given intravenous immunoglobulin infusions, and the parents were asked to come back every couple of weeks, 2 or 3 weeks, and get an echo done. However, unfortunately, the echo never showed any improvement in the ejection fraction. So by 6 months of age, he was referred to us for stem cell therapy, and those were the days when we were doing stem cell for dilated cardiomyopathy in children. However, we realized that no ECG had ever been done on him. And when we got an ECG done as a part of the workup, we were horrified and shocked to see that there were very deep Q waves, suggesting of an infarct pattern with some STT changes. And we repeated the ECG, the echocardiography, and what caught our eye was this dilated right coronary artery, as you see here. This is a short axis, this is aorta, and this is dilated right coronary artery. So we immediately thought that this child has something wrong with his coronaries, which is producing infarction, which is producing left ventricular dysfunction. And this turned out to be a case of anomalous left coronary artery from pulmonary artery, or LCAPA as we call it in short. And it is important to diagnose such cases because you can actually correct these cases by surgery. You put the left coronary back in position, and generally these children improve completely and their LV function improves completely. So this is a sort of a very, very rewarding treatment for this child who was being dumped as dilated cardiomyopathy. This is a 7-month-old child who just underwent an echocardiography for mild and was found to have an ejection fraction of 40% or so, and was being investigated for this mild LV dysfunction. ECG was reported as normal. However, during routine investigation, you can see that his calcium came very low. And when you look again at the ECG, you will realize that there is a marked prolongation of the QT interval. QT is almost 75% of the RR interval. So that is suggestive of a long QT. You can actually do QTC or corrected QT interval. And this was all because of hypocalcemia. And again, those were the days when we were not prescribing vitamin D3 to these infants on a routine. Now we all do that up to 1 year of age. So obviously giving vitamin D3, giving calcium improved his left ventricular function as well. This is another child that came to us with the diagnosis of cardiomyopathy. Again, having an echo already, ejection fraction 35%, ECG interpreted as sinus tachycardia because those who have LV dysfunction are expected to have sinus tachycardia. However, what caught our eye was that his heart rate was almost always fixed. Whenever he came to the OPD, his heart rate would vary between 135, 140. All ECGs looked like that. We also thought that his P wave looks a little abnormal, and the PR interval is a bit prolonged for this RR interval of 150 or so, 140 or so. So he obviously was taken up to the cath lab, and we realized that this was actually a case of tachyarrhythmia. He underwent ablation. ECG post-ablation is shown here, and you can see that the P waves are so much better and the RR interval has improved. Therefore, his heart rate has now become 100 per minute. Obviously, with improvement in his arrhythmia, his left ventricle function also normalized over a period of time. So the cause of LV dysfunction was tachyarrhythmia in this particular case. This is another case where I think ECG made a lot of difference. Being diagnosed as hypertrophic cardiomyopathy, child has presented with cross hepatomegaly and splenomegaly and considered to be having right heart failure. Again, an ECG gave away the diagnosis completely because it was showing very short PR interval and very, very tall QRS complexes in the precordial leads, suggestive of a glycogen storage disease, so typical. So again, here, ECG was the one which immediately gave us the diagnosis. Even, of course, later you can always confirm it with enzyme assay and all that, but ECG was highly, highly suggestive of Pompe's disease. So ECG also is helpful in structural heart diseases. For example, when we are faced with a patient with tetralogy of Fallot's, we don't, or tetralogy of Fallot's physiology, we don't know whether it is TOF, whether it is double outed right ventricle, whether it is tricuspid atresia. An ECG can really give you the diagnosis. This is a child with tetralogy of Fallot's, and what you see is right ventricular hypertrophy. But what is important here is very early transition. So you can see that from V1 to V2, the transitions already happened. Pure R here and almost no R here. This early transition is classical of tetralogy of Fallot's. Of course, if the ECG shows left ventricle hypertrophy and left axis deviation, then we know even before echocardiography that we are dealing with a case of tricuspid atresia. So it is also helpful in many structural heart diseases. And I just want to show you this another case, which I saw about a decade ago. This is a 5-year-old child operated in our own hospital for total anomalous pulmonary venous connection 4 years ago. At 1 year of age, he was quite fine till about 6 months ago. And then he presented to the cardiac surgeon who was following up this child in mild heart failure. Echo at that time was advised, and it revealed that both right and the left ventricles were a bit dilated with somewhat reduced function. There was mild mitral regurgitation, some tricuspid regurgitation, but there was no residual defect, nor was there any pulmonary hypertension. So we didn't understand that why this child who was fine for 4 years or for 3.5 years is presenting in mild heart failure. We thought maybe he has developed some kind of a myocarditis, which is unrelated to his diagnosis. So he was generally started on diuretics, ACE inhibitor therapy from the outpatient itself. He is quite well controlled. However, couple of months later, he came back with nausea, vomiting, very big liver, and was thought to have hepatitis again, had another echo done, not much change in the echocardiographic findings, and therefore he was referred to pediatric OPD for assessment. Patient was admitted, and one of our good pediatric residents, as a part of workup, got an ECG and Xray test done, since it was a post-op patient, and he asked cardiologists to review the ECG and the Xray. And when we looked at the ECG, we were shocked. We never had done an ECG on him before, unfortunately. And look at this ECG. It is so abnormal. It has a heart rate of 150. It has very, very abnormal P waves, which are inverted in 2, 3, and AVF, which is very abnormal, and a long PR interval. So this was actually a case of a tachyarrhythmia. We like to call it permanent junctional reentry tachycardia, or PJRT, which is usually a persistent tachycardia at a rate of 140, 150. And over a period of time, that produces ventricular dysfunction, so-called tachycardiomyopathy. Once we had this diagnosis, it was easy to treat him. We started him on antiarrhythmic therapy. We actually gave him Cordaron, amiodarone to begin with. He converted to sinus rhythm, so we haven't really ablated him, although ablation is a treatment of choice for these patients. And as his arrhythmia improved, his heart function, his failure, everything improved. So we were just missing out on one puzzle piece, which was tachyarrhythmia. And because we had not done an echo earlier, we kept on bothering him with all antifailure medication, giving all kinds of diagnosis, but not thinking of the exact diagnosis, which is tachycardiomyopathy. And we know that post-op TO patients are prone to atrial arrhythmia. So I think we should have thought about it before. This is a 10-year-old girl who presented with recurrent syncope, ECG, echo, Xray, everything reported as normal. But if you look very carefully, then you will find that there is a prolonged QT interval. So this was actually a girl with long QT syndrome. And the dictum usually is that if our QT is 50% or more of the RR interval, it is likely to be prolonged. This QT came as about 500 milliseconds, not very prolonged, but anything more than 50% should be considered as prolonged QT. You can always do QTC calculation using Bassett's formula. Sometimes QTC prolongation is very obvious, like over here. Not only QT is prolonged, but you also have bizarre, inverted, very abnormal looking T waves. So this is all part and parcel of long QT syndrome. And we know that these are the children who are prone to arrhythmias like Torsades de Pointes ventricular tachycardia, specifically precipitated by some of the drugs, for example, antibiotics like erythromycin, azithromycin. So those who have a long QT syndrome need to avoid these drugs. Otherwise, they may go on to develop Torsades de Pointes, which can be a very dangerous arrhythmia for these patients. Other cause of syncope in children could be something called Brugada syndrome. And I just wanted you to have a look at this just to sensitize the pediatric resident that finding this kind of a ST elevation, which is coved, could mean that we are dealing with Brugada. Brugada runs in families. Therefore, you may have a history of sudden cardiac death in the family also. Sometimes the changes are not so obvious, but even here, if you see this coving is quite obviously seen here. So there are different types of Brugada syndrome, but if you find ST elevation in V1, please think about Brugada syndrome. So I would say that any child coming with syncope, look for QT interval and look for any coving of elevation of ST segment in the lead V1 or sometimes even V2, V3. Now, coming to the ICU setting, I think somebody did mention that ECG becomes very important in ICU setting. In fact, this is an ECG very typical of hyperkalemia, and this child had a potassium 7.0. Some of the post-op cardiac patients that we have in the ICU may not have a very good urine output, and these are the patients who go on to develop hyperkalemia. This is really an extreme case of hyperkalemia where potassium has become really high, and you see that the PR interval is prolonged, the QRS is bizarre, merging with the preceding P and the following T wave. And of course, there are very, very tall peak T waves. So this is very classical of hyperkalemia, and this is really extreme hyperkalemia, which can result in arrest very soon and asystole. This is one ECG that often comes to me for referral. This is 8-year-old child which is due for some surgery, referred by anesthesiologist because of irregular heart rate, and the anesthesiology wrote that I should also do an echocardiography to rule out structural heart disease. Clinically, patient had no abnormality, second heart sound was normal, there was no murmur. So this is nothing but sinus arrhythmia, which is something very common in children. And you can see that each P is followed by QRS. Each P is followed by QRS. Yes, there is an irregularity in the RR interval, as you can see, but it is not following any pattern. But the P-QRS relationship is maintained, and that is classical of sinus rhythm. So echo was actually not required. I never did an echo. And I personally feel that this patient should not have come to me. It should have been dealt at the level of anesthesiologist and at the level of pediatrician. Now, I would just like to show you a couple of some more examples regarding X-ray chest. This is another 12-year-old girl. I think I would have seen many, many years ago, who presented with elevated JVP and hepatomegaly, ECG showing sinus tachycardia with some non-specific ECG changes. Diagnosis on echo was restrictive cardiomyopathy of the right ventricle. And this child was told that, look, there is nothing we can do except continue with diuretics and other anti-failure drugs, restrict your salt intake. However, this child obviously continued to do reasonably well, but an X-ray chest done at some point of time showed that there is a very subtle calcification. In fact, calcifications are better seen in lateral X-rays. I'm showing you an AP X-ray because that is what we usually do. So you have to really look very carefully. So this is the calcification. And of course, we confirmed it by CT of the chest that there was a thickening of pericardium with calcification. This was nothing but a case of chronic constrictive pericarditis. And why it is important to diagnose? Because this child can be cured and by doing a pericardiectomy, which will result in complete recovery, very much unlike the prognosis that we have given her based on echocardiography. Another 20-year-old male diagnosed as large AST, referred to us for device closure. And we just got an X-ray done routinely. And you see here that X-ray is classical figure of 8, which is classical of supracardiac TAPVC. And obviously an echo was repeated. And as you can see that there is an AST, but it is going right to left. And there is a vertical vein. Again, very classical features of total anomalous pulmonary venous connection of supracardiac variety. When we looked more carefully, there was a bit of a cyanosis. Saturation was 90% or so. So this obviously cannot be closed with, or should not be closed with device. This adult needed surgical correction. So X-ray is also very, very important. It is diagnostic in some cases, but in most of the time, it can actually narrow the diagnosis to a group of diseases. Yes, there are some classic heart shapes, which I will show you, which may help you to make a specific diagnosis. But also X-ray is very important in pediatric age group for associated pathology. For example, there is a pneumonia or there is a lung hypoplasia or something else which is missed if you don't do an X-ray chest. And of course, for serial comparison. So these are some of the classic X-rays that have been described in the literature. You may find in some cases, not in everybody, a neonate with respiratory distress picture like that of an ARDS. Think about obstructive TAPVC and try to rule that out by an echocardiography. 2-week-old with deep cyanosis, very big heart with, a very specific type of pattern. We call it egg on string appearance or egg on side appearance, very classical of transposition. I must admit that these classical X-rays are not seen in everybody. In fact, they are probably seen in less than 50% of individuals. But if they're present, they're very helpful. If they're not present, obviously you can't rule out a diagnosis. This is a 21-year-old with minimal cyanosis. My resident came to me and said, this could be a patient with tetralogy of Fallot's. I said, look at the X-ray showing a large pulmonary artery segment. How can that be tetralogy of Fallot's? Whatever your echo may show, but this is a case of Eisenmenger syndrome because of severe pulmonary artery hypertension, dilated pulmonary artery segment, very dilated right pulmonary artery with a cutoff, with an abrupt cutoff, classical of severe pulmonary arterial hypertension. 16-year-old asymptomatic boy, huge heart. You have only two diagnoses. One is severe tricuspid regurgitation of any etiology, or it can be Epstein's anomaly. So these are really classical X-rays that if you see, you can make a diagnosis. However, in patients with structural heart disease, and the commonest heart disease that we see would be tetralogy of Fallot's, cyanotic heart disease, you can get a fair idea by an X-ray. Classical X-ray of boot-shaped heart, right ventricular apex upturned, pulmonary bay, sometimes right-sided aortic arch, and no cardiomegaly with abnormally black lung fields, very classical of tetralogy of Fallot's. Or sometimes in a patient which looks like tetralogy, you may have this X-ray where you have an LV kind of apex and no RA. This is like an RA cutoff sign, and this is classical of tricuspid atresia with appendages being juxtaposed. And sometimes in a tetralogy of fallow patient, you find that there is a bulge right here. Now that should not happen because, and this is not pulmonary artery segment, this is upper part of the left cardiac border, which is likely to be aorta. And this is a classical case of corrected transposition where the arrow is pointing to the L post aorta. So sometimes by X-ray, you can make a diagnosis of which kind of tetralogy diagnosis are we dealing with. This is a child who presented with shunt lesions, was carrying an echo report of large left to right shunt, and it was considered to be atrioventricular septal defect. However, what was found on an X-ray is situs ambiguous, something that was not diagnosed in echocardiography. Look, the stomach is lying on the right side, and this child had a midline liver. So this was situs ambiguous. Now, why it is important? Because it would change the prognosis and the outcome of this patient, because we know situs ambiguous is often associated with asplenia or polysplenia, and therefore these children need to be treated with a lot of preventive vaccinations to avoid meningococcal infections and all for rest of their life. So this is again a very, very important part of the treatment of such patients, whatever echo may show. But if there is situs ambiguous, I think that needs to be taken into consideration when treating these patients. And as I said, X-ray is also important for lung pathology. This was a patient who had diagnosis of tetralogy of Fallows. And if we had not done an X-ray, we would have never been able to diagnose that there is left lung hypoplasia. Obviously, echo will not pick that up. Another child who had a large AST and had severe pulmonary artery hypertension. And we were wondering why there is severe pulmonary arterial hypertension, although the heart is shifted onto the right side. But the pathology was that this child had severe right lung hypoplasia, responsible for severe pulmonary artery hypertension, something that should not actually happen with large AST. So that again gave us a diagnosis by an X-ray chest. And in emergency room, sometimes we have to have an X-ray. Patient may be carrying a report of large VST, and you can explain the distress and heart failure with that. But what about the lungs? This is what has pushed him into heart failure, an infection or pneumonitis that this child has come with, and that is why he's in emergency. VST has been there since birth. Why is he become more distressed? Why is in heart failure? And this is where the reason, this is how the reason is. So of course you will give him diuretics, but you would also try to treat his chest pathology. 12-year-old with hypertension, refer for an echo from pediatrics. X-ray chest been reported as unremarkable, except that the aorta is somewhat dilated. But again, nobody had examined the femoral pulses. The femoral pulses were absent. So it was very obviously a diagnosis of coarctation of aorta. But what was missed on the X-ray was this notching of the ribs. If you see carefully, you can actually see the notching now. But obviously it was missed initially because we didn't think about coarctation as a diagnosis. Again, very simple. Treat with balloon dilatation with or without stenting, and hypertension will be taken care of. This is another strange case that I have seen. The 16-year-old on a long follow-up from outside, diagnosed as having mild ASER, annual echoes being done, no progression of aortic stenosis, no progression of aortic regurgitation, child and family being assured that everything is fine, just come for annual follow-up. Nobody did an X-ray. And if you look at the X-ray, you find that ascending aorta is so much dilated. Again, when you do an echo, in 12-year, 14-year, 16-year, you may not be able to see ascending aorta on echocardiography. But look at the X-ray, very clearly showing something like an aortopathy. And we know that bicuspid aortic valve is associated with aortopathy. And what this child needed was beta blockers, because this aortopathy has to be stopped from progressing, and either use beta blockers or use angiotensin receptor blockade, whichever drug, but he needed that drug, which was obviously not given to him all these years. And finally, I think X-ray chest is indispensable for children with permanent pacemakers. All these children, when they're coming for follow-up with us, are being followed up for X-ray chest, because you have to see whether the loop that you've made of the lead is in right position or not. As a child grows, this loop is going to open. And if we have not done an X-ray, we will not know where the lead positions are, like over here, like over here. And there is no other investigation which will tell you where the lead is, but an X-ray chest. So this is serial X-rays have to be done on these children when they're coming to us for pacemaker interrogations. So let me just conclude by saying that X-ray and ECG have the ability to detect diverse types of cardiac diseases. Sometimes they can diagnose the disease with complete precision, but sometimes they can give you an indication as to what you're dealing with. They obviously have a very low cost, they are very quick to carry, and they are widely available in every corner of any region. ECG essentially has no risk, we all know. X-ray does carry minimum risk of radiation, and therefore one has to be a little more careful while ordering serial X-rays. They're also very useful in serial follow-up. So let me put my case back. ECG and X-ray chest continue to enjoy the prestige, the reputation, the dignity, and the glory in the present era and remain essential tools in the modern clinical medicine. Thank you very much for your attention.
Thank you, madam, for your excellent deliberations. Actually, you have told all our attendees that the importance of the basics, like the ECG and the X-ray. So there is one question, madam. So some Minal Desai from Howrah, she asked for the ECG of the patient of the Al-Kappa.
Okay. Sure.
There is another question, Sapun, before that. Okay. I did after that.
Yeah.
Let me just show the ECG of the Al-Kappa. So this is the ECG. If you see carefully, it shows very deep Q waves in one AVL, and also in V5 and V6. And there are some STT changes also, like T wave is inverted over here, T wave is inverted over here. So such deep Q waves are suggestive of infarct pattern, no typical myocardial infarction that we see in adults. So this was highly suggestive of the fact that there is some ischemia that is happening. And that is what gave us a clue that this is likely to be a case of Al-Kappa. And let me just share with you that Al-Kappa patients invariably will have infarct pattern. And therefore, any child coming to us with a picture like that of dilated cardiomyopathy must undergo an ECG to rule it out. Now, of course, with a good echocardiogram, you can rule it out. And as we could do over here, that there is a left coronary artery coming off pulmonary artery, but it is also very easy to miss it because coronaries are not very often seen on echocardiography. And therefore, any dilated cardiomyopathy patients comes to us, it is imperative for us to look at the coronary arteries on echocardiography. And if you're not able to see, it may be even better to go for some investigation like an angiography or CT angiography to be very, very sure. There are instances where I could not diagnose Al-Kappa on echo, but I was...
Didn't get that. Could you try again?
I could not diagnose Al-Kappa on echo, but I was very convinced on the ECG. And therefore, I actually have gone to do CT angio of this patient to confirm that I was dealing with Al-Kappa. So it is not a very easy diagnosis on echocardiography.
So I think the other question asked by Dr. Malavika Maiti has already been answered by Professor Saxena. So she asked about how ECG can help in Al-Kappa. So you have already answered that.
No, Al-Kappa with good collaterals.
So
she has asked the Al-Kappa with good collaterals in a 4-year-old girl child. So how ECG can help, man?
See, again, I would like to say that Al-Kappa, even if it has good collaterals, unfortunately, that won't happen by 4 years of age. It usually happens after, 6, 7 years or 10 years or 12 years. But invariably, it shows infarct pattern somewhere or the other. It may show in the 1 AVL, it may show in V5, V6. But yes, I have a 56-year-old lady with Al-Kappa where the ECG did not show typical infarct pattern, but she had poor LV function. She had mitral regurgitation. We took her for cath and we were surprised to see that she has Al-Kappa. So rarely you may have cases where you may not be able to see typical ECG, but in pediatric age group, usually we see a typical ECG of Al-Kappa, even if there are collaterals. In fact, they are living on collaterals. Collaterals are necessarily have to be there. Otherwise, they will die. They will not live. So they are getting collaterals, but one must remember that collaterals are never sufficient. And that is the reason why they still have ischemia and infarction.
Another question from Dr. Narayan Santuga. Madam, I have a patient of long QT syndrome diagnosed as a case of the KCNH2 mutation after genetic analysis. Currently, the child is on propranolol prophylaxis. How frequently should we do ECG in that patient?
In fact, if it is long QT syndrome, then propranolol has to be given very high doses. So our problem in those cases is bradycardia, how to manage bradycardia, because the doses that you use of beta blockers in patients with long QT are really, really huge, something like 10 milligram per kilogram or something like that. Otherwise, it is not very effective. In fact, majority of these patients should have ICD to prevent sudden death. But if you are putting them on beta blockers, sometimes in pediatric age group, we do that because putting an ICD in a child becomes a bit difficult. But if there is family history of SCD or something, I would still advise to go for an ICD. But if we are using propranolol, then it is the heart rate that you are always bothered about. If you can shorten the long QT by propranolol, then it is fine. But majority of the time, you can't normalize QT in such patients. So you can do ECG, initially maybe every 2-3 months. But once the patient is stabilized, you could do it every 6 months or so. But you have to keep an eye on heart rate because you have to you have to go to maximum tolerated doses of beta blockers.
Thank you. Another question by Dr. Sujay Chaudhary: why amiodarone is not used in the torsades D points treatment?
Any drug that prolongs QT interval cannot be used. In fact, amiodarone can produce torsade D points. So amiodarone, disopyramide, a lot of these antiarrhythmics which actually prolong QT interval cannot be used because that is the cause of torsade D points. So that's why we don't use it. We often use beta blockers.
What other modalities of management should we go and when?
For which disease? I didn't get that question.
Particularly the prolonged QT syndrome.
Okay, so the various modalities that we have for long QT, of course, I said ICD, but you could also go for something called left sympathetic ganglionectomy. There is some data which says that long QT can be controlled with that also. So it depends how symptomatic patient is. Every long QT doesn't need to be treated, but if there are arrhythmias, if there are family history of sudden cardiac death, you may have to be very aggressive. Otherwise, you could go with beta blockers only. So it really depends what are the symptoms, whether there's a family history of SCD or not. And then accordingly, you can be very, very aggressive. So you could start with beta blockers. You could go to left steroid ganglionectomy. Of course, ICD will always help to give a shock in case there is ventricular tachycardia.
Thank you, madam. So now we'll move on to our next session. So today's conveners are Dr. Debabrata Nandi and Dr. Lopamita.
Dr. Safwan, I think there are 2 more questions that to be addressed. PGRT, how can be diagnosed and confirmed in DCM investigations?
So PGRT is diagnosed basically by ECG only. I think majority of us can diagnose PGRT by ECG. It shows P waves and it shows long PR interval. Also, one thing that we should remember is that PGRTs are usually not very fast. They're more like 150. So very often they're missed as sinus tachycardia because you always think, okay, 150 is not so fast. How can it be supraventricular tachyarrhythmia? But PGRTs are persistent. They go on for days, months, years, and they destroy the ventricle. They reduce the ventricular function. And that is why it is important to diagnose. But P wave always looks abnormal. PR interval is abnormal for that heart rate. But yes, where this is coming from, what is it, focus that we usually see in the EP lab. So once you make a diagnosis of suspicion of PGRT, it is best to take them to the lab, ablate it. But yes, in small children, sometimes we try and control it with drugs only. And if it reverses to sinus rhythm, you can wait for some time for the child to grow and then go for ablation. But sometimes PGRT can be very difficult to treat medically. In those cases, it is best to take these children to the lab, of course, by an expert in EP and get it ablated in the lab.
Thank you. There are a few questions. I think our expert is Dr. Debashree Ganguly. Debashree, if you can please answer to the rest of the questions. So that we can move on the next session. So I will just hand over this thing to Dr. Debabrata Nandi and Dr. Lopamita Mishra to continue. And madam, again, thank you so much. We are overwhelmed by your presence and the lucid talk and for your question answering session. Thank you very much.
Thank you, madam.
Thank you, madam. After the, as usual, outstanding and mesmerizing guest lecture by none other than the mother of pediatric cardiology of India, Dr. Professor Anita Saxena ma'am, we are going to start our basic lectures today. And I'd like to invite Dr. Saptaki Das for delivering the lecture on the principle and techniques of recording of ECG. Dr. Saptaki Das, who did MD, DCH and MRC PCH, and following that, he did his fellowship in pediatric cardiology, and presently he is working as an AP in ICH Kolkata. Dr. Saptaki Das.
Hello, am I audible?
Yes.
You are audible.
Okay. Thank you. I would like to congrats everyone to attend this session of WAP. Special thank to Dr. Shapon Roy to give me a chance to present in this session. So today the discussion topic of mine is the principle and technique of pediatric ECG. So before the current era of cardiac imaging, ECG was considered a key tool in the diagnosis of congenital heart disease. It remains a very important tool in the follow-up of children with corrected and palliated congenital heart diseases. One minute. It helps in the evaluation of common clinical symptoms such as chest pain, palpitation, breathlessness, and syncope. So actually, pediatricians lack the familiarity about the systemic interpretation of ECG. So in this session, we'll discuss the basic and easy ECG approaches. So by definition, ECG is the record of the algebraic sum of electrical activity, that is the action potential generated by the heart during the cardiac cycle. It is based on the principle that when the depolarization wave spreads through the heart, electrical current passes into the surrounding tissue and can be recorded from the electrodes placed on the skin opposite to the heart. As we know, the body fluids are good conductor of the electricity. We should also keep in the background that there are some certain physiological changes that occurs, and the ECG also changes accordingly. The ECG changes during the first year of life reflect switch from fetal to infant circulation, changes in the systemic venous resistance, and increasing the muscle mass of the LV. The size of the ventricles changes as the infant grows into adulthood, childhood, and adulthood. Initially, the RV is larger and thicker at birth due to, we know, the physiological pH, there's a neonatal pH is present, and by approximately at 1 month of age, LV will be slightly larger. By 6 months of age, LV is twice the size of RV, and by adolescence, it is almost 2.5 times size of the RV. So, what to detect in the ECG? So, from ECG, we can detect any electrolyte disturbance, such as ma'am told, hyperkalemia. We can detect also hypokalemia and hypocalcemia, conduction defects, such as various kinds of tachy and bradyarrhythmias. We used to calculate the heart rate, what is the axis and rhythm. In certain myopathies, such as Duchenne muscular dystrophy, we can detect the amount of left ventricular hypertrophy. In certain carditis, such as rheumatic and myocarditis, we used to detect the PR interval, the ST changes. In chamber hypertrophy, such as in pulmonary hypertension, the right atrial and right ventricular hypertrophy, we can detect by ECG. And also in the myocardial ischemia and in some drug toxicity, such as digoxin. So For the technical aspect of ECG, we will discuss lead placement, the vectorial approach to assess the rhythm, calculate the heart rate, interpretation various kind of ECG waves and QRS axis, and reading of the ECG. So coming to the leads, so normally there are 12 leads. Among these, there are 6 limb leads and 6 chest leads. Among the 6 limb leads, there are 3 unipolar leads and 3 bipolar leads. The unipolar leads are AVR, AVL, and AVF, and the bipolar leads, they are the standardized limb leads, that is lead 1, 2, and 3. And 6 chest leads are V1 to V6. The standard limb leads is suggested by William Inthoven. The augmented limb leads by the scientist Dr. Goldberger, and precordial leads by Frank Winson. So what are the unipolar and what are the bipolar leads? When 2 active electrodes attach to the surface of the body, it means the ECG is recorded from the 2 electrodes. They are the bipolar leads. These are the standard leads, that is lead 1, 2, and 3. And unipolar leads are the one point of the body acting as an active electrode, and in the virtual reference for the indifferent electrode with a 0 electrical potential, then it is called the unipolar leads. So Einthoven first described the triangle in which the heart is keeping on the center, and we assuming a triangle. So keeping the leads in the right wrist joint, left wrist joint, and the left foot. He described a law which states that if an electrical potential of any 2 of the 3 bipolar limbs are known, the third one can be determined mathematically by summing the first 2. And the sum of the voltage of lead 1 and lead 3 is equal to the voltage of lead 2. And the triangle is drawn around the area of the heart. The 2 apices at the upper part of the triangle represent at the point at which the arms are connected electrically, and the lower apex is the point at which the left leg connects. So likewise, the electrodes are attached to the skin surface of the right arm, left arm, and the left leg. The lead 1 is between the right arm and left arm, lead 2 between the right arm and left leg, and lead 3 between the left arm and left leg. So a lead is consisting of 1 positive and 1 negative electrode. Now, what are the augmented unipolar limb leads? The 2 limbs are connected to the negative terminal of the ECG, and the third limb is connected to the positive. The augmented right AVR lead is attached to the right arm, AVL is attached to the left arm, and AVF is attached to the left leg. So this is the typical the position we used to attach the lead in ECG in the right arm or wrist, left forearm or left wrist, in the left lower leg, and V1 is the 4th intercostal space, the right sternal edge, V2 in the 4th intercostal space in the left sternal edge, V4 in the 5th intercostal space in the mid clavicular line, and V3 midway between the V2 and V4. V5 in the same plane with the V4 in the anterior axillary line, and V6 in the mid axillary line in the V4 and V5. The augmented limb is 1.5 times of the unipolar lead, because as is the vectorial approach, we will determine the augmented lead is 1.5 times of the unipolar leads. Now coming to the vectorial approach, so it allows us to understand the electrical activation of the heart from a three-dimensional perspective. The limb leads provide the information about the frontal projection, that is the frontal plane, reflecting the superior to inferior and right to left forces. So they are the leads with the standardized limb leads, that's lead 1, 2, and 3, and augmented leads. And the precordial leads, that is V1 to V6, provide information about the horizontal plane, which reflect the forces that are right to left and anterior to posterior. So there are two systems that is working. One is hexaxial system or frontal system, and another one is horizontal system. This is the two system. In the left, we are seeing the frontal system, where the lead 1 depicted by 0 degree and lead AVF by the 90 degree. And the right sided, we are seeing the horizontal system, that is lead V1 to V6. Sometimes we place also right sided V4 leads in case of right sided chamber enlargement. In that case, we place V4R. So the picture is not coming actually. Now this is the ECG paper calibration. So ECG is displayed on a graph paper as waves. The speed of the paper is 25 millimeter per second. The x-axis is depicted by the time. So 1 millimeter square is 0.04 second, and the y-axis is depicted by the millivolts. Is 1 millimeter square equal to 0.0 millivolt, and tails small line is 1 millivolt. Now, what is the normal rhythm? So the electrical activity of the heart is initiated at the sinus node, and after depolarization of the atria is conducted to the ventricles through AV node. This is termed as sinus rhythm. So in simple words, sinus rhythm is the normal rhythm at any age and is characterized by P wave preceding each QRS complex and a normal P axis. For P axis to be between 0 to 90 degree, P wave must be applied in lead 1 and lead AVF. Now, to calculate the heart rate, so standard ECG paper speed is 25 millimeter per second, and 1 millimeter equal to 0.4 second. So the calculation is 1500 divided the number of small squares between the two consecutive R waves. Now coming to the normal ECG waveform, there is first P wave, then QRS complex, and the T wave. P wave caused by atrial depolarization is precede atrial systole and represent the time of electrical impulse from SA node to spread through the atrial muscle. QRS complex is caused by ventricular depolarization. First, the Q wave is depolarization of the interventricular septum. The R wave is the depolarization of the ventricular wall, and the S wave is depolarization of the base of the heart. T wave caused by the ventricular depolarization precedes the ventricular diastole. Now, in normal sinus rhythm, the P wave morphology will be normal in lead 2. When in case of right atrial enlargement, the P pulmonary will be seen. That is the P wave more than 2.5 millimeter, the lead 2. And in left atrial enlargement, the P will see the P mitral. That is the bifid type of P waves of over a more span of 120 milliseconds. So the sequence event is that first the atrial depolarization initiated by the SA node causes the P wave. Second, with atrial depolarization is complete, the impulse is delayed at the AV node, which is called AV nodal delay. Third, the ventricular depolation begin at the apex, causing the QRS complex, and in the same time, atrial repolation occur. Next, in the ST segment, the ventricular depolation is complete. In the T section, we see the ventricular depolation begins at the apex, causing the T wave. And lastly, the ventricular depolation is complete, depicting that followed by the T waves up to the next T wave. Now, how to determine the QRS axis? So it is determined by the deflection of two perpendicular leads, that is lead 1 and AVF. So when in lead 1 is depicting the positive and lead AVF also the positive, the QRS axis is normal. In case of negative deflection in the lead 1 and positive in lead AVF, we will see the right axis deviation, which can be normal in infants but abnormal in children. In lead 1, if it's the deflection in R wave is positive and lead AVF is negative, it is the left axis deviation is always abnormal. It is seen in case of tricuspid atresia, some posterior muscular VSDs, certain cardiomyopathies, and Noonan syndrome. And if the both leads are negative, that is the extreme QRS axis, which is seen in AV canal defect, which is Down syndrome. So QRS axis and ventricular dominance. At birth, the axis is markedly rightward. As the LV mass grows and becomes the dominant, the axis gradually shifts by the 1 year of age. So in the infancy state, we can see the right ventricular dominance or RV dominance. Now coming to the T wave, the T waves are frequently upright through the precordium in the first week of life. Thereafter, T waves in the V1 to V3 is invert and remain inverted from the newborn period until 8 years of age. This is called juvenile T wave pattern. Upright T waves in the right precordial leads can indicate RVH. So we now in the ECG, there are some intervals. There are PR intervals, QT intervals, and RR intervals. PR intervals is calculated from initiation of P wave, that is atrial depolation, to the QRS complex, that is the ventricular depolation. The normal value is 0.12 to 0.02 second. Includes POF, which denotes the atrial depolation, and PR segment. The atrial depolation is denoted by POF, and PR is the AV nodal delay. So an increase in the conduction velocity through the AV node will decrease the PR interval and vice versa. So the represent the AV nodal delay. The ST segment represents the complete depression of ventricular muscles. So no potential difference between the myocardium at this stage. And the TP segment, that is present ventricular filling, the repolation and depolation. So in the basic, if we can get this ECG, the ECG recording. So first coming to the rhythm, so we have to see the P wave. Here the P wave is QRS complex, that is the sinus rhythm. Next, to calculate the heart rate, the heart rate is 1500 divided number of small square between RR. Here the RR interval is almost 16 small square, so 1500 divided by 693. Coming to the determination, you have to see the QRS complex in lead 1 and AVF. So both are positive. So this is a normal axis. Here morphology, and see it will be divided by the square root of RR interval, which is so it's a normal study. Thank you. This is from my end.
Dr. Swapan, please respond.
Actually, Lopamudra will be doing this. Lopamudra and
Lopamudra, Dr. Lopamudra.
they are the convener today.
Our next topic is how to read a pediatric ECG by none other than Dr. Dhitobroto Das. Dr. Dhitobroto Das sir is an renowned and eminent pediatric cardiologist of India. And after post-graduation in pediatrics, he has completed the fellowship in pediatric cardiology in India and then from CHW, Australia. He is currently working as a visiting consultant in pediatric cardiology at Amri and Apollo Hospital. Please welcome Dr. Dhitobroto Das sir.
Okay, 1 minute before you are starting the Dr. Dhitobroto, I request Dr. Satyaki, please answer the questions which are posted in the chat box to save the times. And welcome Dhitobroto, and we start your deliberation.
Thank you. Can I share my screen? Can you hear me?
Yes, yes.
I'm unable to share my screen.
Dr. Somnath, please help him.
I'm clicking on that one, but it is coming as just a minute.
Satyaki, there is a request to share your PDF in the group.
And Dr. Swapan, I think all the materials will be available for the who are registered.
Yeah.
Is there a share screen option? Can you?
হ্যাঁ পাচ্ছি কিন্তু ওটা ওপেন করতে গেলে saying that it is
Host should get permission. তুমি permission দিয়ে দাও.
Just a minute.
Satyaki, go on answering the question. There are a lot of questions in the chat box. And all the participants are requesting for the PDF of your presentation. So please assure them.
Somnath da? It is showing allow Zoom to share your screen and then open system preference. There is some security related issues coming up.
তাহলে তুমি কাউকে শেয়ার করবে? তোমার প্রেজেন্টেশন শেয়ার করা আছে কি?
Yes, না করা নেই. What I will suggest, can we start the next speaker? So I will come back and sort out this issue by that time.
Okay, no issue. Ask Lopamudra, please invite next speaker.
Yes, ma'am. So we'll start with our next topic, that is ECG changes in congenital heart disease by Dr. Devabroto Nandi. Dr. Devabroto Nandi has done MD Pediatrics, following which he has completed his FNB Pediatric Cardiology, and then he had done another fellowship from the Australia on pediatric cardiology. And then he is right now working as in the RNT as a clinical lead and consultant and clinical lead in the pediatric cardiology. So I'd like to welcome Dr. Devabroto Nandi.
Good evening, everyone. Hope I'm audible and my slides are visible.
Yes.
So first of all, I'd like to thank the West Bengal Academy of Pediatrics for giving me this opportunity to speak in this session. So today I'm going to speak about the topic of ECG in congenital heart disease. I'd like to start with this quote from Alexander Nadas that ECG, accurate physical examination X-ray from the typhoid, on which basis we have a bedside diagnosis of a congenital heart disease. I will try to cover some basics of ECG, age-related changes, chamber enlargement, common congenital heart disease, and the ECGs and ECG used in differential diagnosis. So congenital heart disease is just like a jigsaw puzzle, and ECG is one of the missing blocks which we need to take care of after knowing the history, thorough clinical examination, measurement of the saturation and blood pressure, X-ray, and finally, before sending the patient to echocardiography for getting a detailed diagnosis of congenital heart disease. It provides a diagnostic tool for the detection of the congenital heart disease, but the crucial data that is needed before interpreting an ECG is the age of the patient, presence of cyanosis, and X-ray to know at the increased pulmonary blood flow or a decreased pulmonary blood flow situation. This is a hexaxial reference system which shows we have these limb leads 1, 2, 3, AVR, AVL, and AVF, which gives an idea about the orientation of the heart in the frontal axis, and the chest leads or the precordial legs from V1 to V6 and the right-sided leads, which gives an idea about the orientation of the heart in the horizontal plane. So by this time we know that we can get the axis from two leads which are 90 degrees to each other. So we commonly take lead 1 and AVF. So if both are positive, it's a normal axis. If AVF is negative, it's a possible left axis. If one is negative, it's a right axis, and if both are negative, it's an extreme axis. A very important concept was the rotation of the heart. So normally, we know that RV is an anterior structure and LV is a posterior structure. So in figure, if there is a clockwise rotation, then what happens is the RV becomes anterior and the LV goes posterior. So which is denoted in the ECG by a presence of QFs in the inferior leads, that is Q3 and AVF. If there is a counterclockwise rotation, then the LV comes a bit anterior and there is QFs in 1 and AVL. Now, identification of the situs. So in situs solutus, the POV morphology is from the RA and the POV axis is plus 60 degree around. So we have the positive POV in 1 and AVF and inverted in AVR. Situs inversus dextrocardia as a mirror image dextrocardia. The POV is arising from the left side, so the morphological RA is on the left side. So the POV axis is plus 120 degree. So there is a negative POV in 1 and positive in AVF and AVR. We have another rhythm when the POV axis is coming from down or the base or from the coronary sinus. It is known as the low atrial rhythm, characterized by positive P in lead 1 and negative in AVF. Normal ventricular depolarization pattern, it starts from the septum and followed by RV and activation of RV and LV simultaneously. Now, the opposing forces, you know that when there is a opposing electromotive forces, they cancel out each other. So the thick or the major ventricle will determine the major vector of the axis. Now, the direction of the septal depolarization is initially from LV to RV. That's why we get a initial QF in left-sided precordial leads, that is V5, V6, and a small ROF in V1 and V2. So these are normal 12-lead ECG. You can see normal axis. There is presence of QF in V6 and normal RFs in V1. In right bundle branch block pattern, the RV is depolarized to the ventricular myocardium. There is terminal slurring of the QRS complex. There is presence of white RF in right-sided precordial leads, known as the M pattern, or the slurred SOF in the left-sided precordial leads. So this ECG shows a RH R dash or RBB pattern in the right precordial leads V1, V2, and V3. Left bundle branch block, abnormality of the septal depolarization with loss of QFs in V6. There is wide slurred RFs in the left precordial leads and slurred SOFs in the right precordial leads, just the opposite of RBB pattern. So you can see that there is a RH R dash or the M pattern in the left precordial leads V4, V5, V6. Now some age-related changes. So we know that at birth, the RV is dominant due to fetal circulation. After that, this progressive reduction in the pulmonary vascular resistance and increase in the systemic vascular resistance. So the ECG at birth, there is RV dominance which changes to LV dominance. However, in premature intervals, extreme premature, less than 28 weeks, LV is predominant. It is characterized by LV dominance and lower voltage in the limb plates. There is TO inversion in the V1 and there is left axis deviation. In term newborns, there is right axis deviation. It can be till 180 degrees, whereas the mean QRS axis is around 110 degrees. There is RV dominance with tall R in V1 and deep S in V6. T wave in V1 is upright at birth and it becomes inverted by 1 week and remains so till adolescence or puberty. So as the age progresses, there is progressive reduction in the right axis deviation and the axis becomes less than 90 degrees. There is progressive RS progression, just like an adult pattern. T-wave inversion can be present till early adolescence, and in adult life, like after 18 years, the T-wave is upright in V1 and V2. This is known as the juvenile T-wave pattern. Atrial enlargement, right atrial enlargement, the P-wave is more than equal to 3 mm in lead 2 and V1. And left atrial enlargement, prolongation of the P-wave duration more than 0.1 seconds and 0.08 seconds in infants. There are a few criteria. One is the Morris criteria. which is the negative component of the biphasic Q wave, is more than 1 millimeter and the duration is more than 0.04 second. We have the Macrose index, which is the P wave duration by PR interval more than 1.6, which denotes left atrial enlargement. We have the combined atrial hypertrophy. In ventricular hypertrophy, it can be concentric hypertrophy due to pressure overload or eccentric hypertrophy due to volume overload. It can be a right ventricle, left ventricular, or a biventricular hypertrophy. Right ventricular hypertrophy, we have different criteria. So increase anterior and rightward QRS vector with tall R waves in V1, V2, and all the right-sided leads like V4R, and deep S waves in lead 1 and V6. So we can see the tall R wave in V1 and deep S wave in V6, and the RS ratio in V1 more than 1 denotes right ventricular hypertrophy. Deep Q wave in V1 also is a sign of right ventricular hypertrophy. Prominent RF in the right precordial lobes like V1, V2, V3 with asymmetric inverted Q wave, also known as the RV strain pattern, denotes significant RVH. RS-R' pattern in V1 is sensitive but not specific. R prime wave in children less than 1 year more than 15 millimeter, or in children more than 1 year with more than 10 millimeters suggests right ventricular hypertrophy. We have several criteria for the left ventricular hypertrophy. There are several criteria out of which the Sokolov line criteria is well accepted. This says that S wave in V1 and R wave in V5 is more than 35 millimeter. R wave in lead 1 and S wave in lead 3 more than 25 millimeter. R in AVL is more than 11 millimeter, and R in V5 or V6 more than 26 millimeter. So we can see the voltage criteria. The tall R wave in V6 and the deep S wave in V1 denotes LVH. Now we'll come to the shunt lesion, the acyanotic congenital heart disease. We have divided the acyanotic congenital heart disease into two types: increased pulmonary blood flow situation and normal blood flow situation. Left ventricular hypertrophy or biventricular hypertrophy can be present in VSD, PDA, or AV septal defect. Right ventricular hypertrophy can present in ASD, EFPVC, or TAPVC, and pulmonary vascular obstructive disease or Eisenmenger syndrome, or any conditions related to pulmonary arterial hypertension. Normal pulmonary blood flow situation with LVH is present in aortic stenosis, some forms of aortic regurgitation if it's significant. Coarctation of aorta after infancy will present as LVH, whereas coarctation in infancy will present as RVH. Other causes of RVH are valvar pulmonary stenosis and mitral stenosis. We'll come to ASD, or the atrial septal defect. So the most common characteristics: RS-R' pattern in the right precordial lips with the sign of RV volume overload. Sometimes it is denoted as incomplete RV, which is a misnomer because in an uncorrected ASD, basically there is no block. So there is no right bundle branch block. It is due to the prolongation of the fibers. There can be prolonged PR intervals, especially if the ASD is associated in a case of ostium primum ASD. The QRS axis is vertical. It can be right axis deviation with clockwise loop, which denoted by Q waves in the inferior leads, that is 2, 3, and AVF. Right axis deviation with pure R waves in the V1 can be a sign of development of pulmonary arterial hypertension. Atrial arrhythmias like atrial flutter, fibrillation, paroxysmal atrial tachycardia are present in ASD, uncorrected ASD in later life, like in after 4 decades. Crockett's sign, this is the notch on the inferior leads, like a M pattern or a bifid at the zenith of the R waves, is present in leads 2, 3, and AVF. It's highly specific for ostium secundum ASD. It denotes RV dilatation reflected in the inferior leads. It predominantly occurs in a long-standing shunt, hence not present in infancy, it's present in older children. So these are ECG. So you can see the lead 1 is isoelectric, AVF is positive, so it's a vertical axis, and there is a RS-R' pattern in the right-sided precordial leads. This is an ECG which shows the Crockett's pattern in inferior leads, that's lead 2, 3, and AVF. So as pulmonary arterial hypertension develops, the RS-R' pattern gives way to isolated R wave in V1, and signs of pulmonary arterial hypertension like right axis deviation and right ventricular hypertrophy develops. After surgery, the R wave may revert to RS-R' pattern in 40% of the patients. In ostium primum ASD, as a part of AV canal defect, there will be counterclockwise looping with Q waves present in 1 and AVL. Left axis deviation with extreme LAD present in Down syndrome. There can be prolongation of PR interval or first degree heart block. RV is presented by tall RVs in V1, signifying development of PH. Right bundle branch block pattern appears as the right bundle is long due to the anatomy. So right atrial enlargement, RVH, left axis deviation with first degree heart block is indicating of ostium primum ASD. In PFO or the patent foramen oval, ECG is normal. In sinus venosus ASD, there is ectopic atrial pacemaker and inverted POFs in the inferior leads. There is 2-3 AVF and positive in AVR. If it's a common atrium, commonly associated in a heterotaxia or isomeric heart, there can be combined signs of ostium secundum, ostium primum, and sinus venosus defect. The important point to mention is that the first degree AV block is seen in ostium secundum ASD associated with Holt-Oram syndrome. This is a sinus venosus ASD ECG, which shows an inverted P wave in the inferior leads, that is lead 2, 3, and AVF. So a quick recon. So P wave axis is a superior axis in sinus venosus ASD. QRS axis is left axis deviation in ostium primum and normal or right axis deviation in ostium secundum or sinus venosus ASD. There is anti-clockwise looking in ostium primum ASD. First degree heart block and pulmonary arterial hypertension is common in ostium primum ASD as a part of AV septal defect. Lutem-Becker syndrome, congenital ASD with an acquired mitral stenosis, mostly rheumatic, will present as a left axis enlargement with right ventricular hypertrophy. Atrial arrhythmias are more common in this condition. VSD, hemodynamics will depend on the presence and degree of volume overload, which will cause a eccentric hypertrophy, or a presence or degree of pressure overload, which will give rise to a concentric hypertrophy. A small restrictive VSD with normal size left ventricle, left atrial will have a normal tracing. It is a moderate VSD with dilatation of the LA-LV. There will be broad notched P wave and signs of LV volume overload denoted by tall R and tall peak T waves in the left precordial legs V5 and V6, and also in the inferior leads 2-3 AVF with presence of deep Q waves in V5 and V6. Non-restrictive VSD with pulmonary arterial hypertension will have biatrial and a biventricular hypertrophy, also known as the Catt-Wurzel phenomena, which is the equiphasic RS waves in the mid-precordial leads. Usually VSD have a normal axis. However, left axis deviation in VSD can be present in 40% cases of multiple VSD, 5% cases of PM VSD, inlet VSDs, and higher incidence with a ventricular septal aneurysm. And some form of DORV and CTG with VSD can have a left axis deviation. I'll come to that later. So Catt-Wurzel phenomena, the RV systolic overload due to hyperkinetic pH and LV diastolic overload due to increased pulmonary venous return. The mid-precordial leads can be as high as more than 50 mm. There are prominent Q waves and tall R waves, tall T waves in the left precordial leads. So as you can see, this is a 12-lead ECG sinus rhythm, normal axis with prominent equiphasic RS voltages in the mid-precordial leads V2, V3, V4, which denotes a Catt-Wurzel phenomenon. So evaluation of VSD, and if the VSD goes to a pulmonary arterial hypertension and Eisenmenger, there will be biatrial enlargement, predominantly right atrial enlargement. There will be increase in right axis deviation, monophasic RF in V1, and absence of Q wave in the left precordial legs like V5 and Z6, also taken as a criteria for inoperability. A moderate restrictive VSD, like if the VSD is associated with a RCC prolapse or right coronary graft collapse, and there is presence of moderate aortic regurgitation, there can be deep Q waves, tall R waves, and deeply inverted Q waves like a LV strain pattern. Garbody defect or a LV to RA shunt, there will be volume overload of all the 4 chambers. But the classical is right atrial enlargement with left ventricular volume overload denoted by deep Q and tall R waves in the left precordial leads. Patent ductus arteriosus or an PD or an AP window, which is moderately restricted associated with LA and LV enlargement, there will be again signs of LV volume overload, tall R waves and deep Q waves and straight T waves in the left precordial leads. Non-restrictive PD or a large PDA with presence of pulmonary arterial hypertension, there can be presence of biventricular hypertrophy with large equiphasic R waves like a Catt-Wurzel phenomena present in a non-restrictive VSD. QRS axis in PDA is essentially normal. However, there are a few conditions which will come later. In Eisenmenger syndrome, there is right atrial enlargement, right axis deviation with right ventricular hypertrophy. Now, if a non-restrictive PDA goes into develops a pulmonary arterial hypertension, the QFs in the left precordial leaves V5 and G6 persist even after development of PH, and this is a differentiating point in case with a non-restrictive VSD in which there is an absence of QFs in V5 and V6. So PDA in a congenital rubella syndrome will have a superior axis. PDA in a newborn will have a right axis. And if the PDA is associated with coarctation of aorta, there can be left ventricular hypertrophy with secondary STT changes. So this is a ECG of a patient with a PDA. So this shows a normal axis with equiphasic RS voltages in the precordial leaf showing a cat-Torzell phenomena. This is a case of a non-restrictive PDA. Complete episeptal defects is associated with first degree or a first-degree heart block or a prolonged peer interval in 50% of the cases. Left superior axis or extreme LAD present in Down syndrome. There is presence of counterclockwise looping, which is signified by the presence of QFs in lead 1 and AVL. Right ventricular hypertrophy is present because mostly there is presence of pulmonary arterial hypertension due to non-restrictive VSD. So this is the 2 lead ECG. As you can see, there is so it's positive in lead 1 and negative in lead 5, lead AVF. So there is left axis deviation. There is prolonged peer interval of the first degree heart block. There is right atrial enlargement, and there is counterclockwise looping with the presence of QAV in 1 and AVL. Will come after the shunt lesion. Will come to the stenotic lesions. So now with the normal or a decreased pulmonary blood flow situation, in the right side of the heart, we have the valvular pulmonary stenosis, double chambered right ventricle, or a peripheral pulmonary stenosis. So pulmonary stenosis will give rise to a pressure overload situation on the RV. So there will be right ventricular hypertrophy with right axis deviation and RV with strain pattern. Tall monophasic ROs present in V1 and deep SOFs present in the V6. Normal height of ROs in V1 is less than 8 mm in infancy and less than 10 mm in children. Persistent upright TOF in V1, V2, even after 1 week of age or 1 week of age, will indicate a presence of significant right ventricular hypertrophy. Pulmonary stenosis. So as the pulmonary stenosis gradient increases, the height of the ROF increases, and there is right axis deviation. It can be in case of severe PS, there can be extreme right axis deviation more than 150 degrees. An assessment of the right ventricular systolic pressure, we can get it from the height of the RFs in the V1 multiplied by 5 times or 3 times of the V1 plus 47. We can get an assessment of the gradient of the pulmonary stenosis by this method if pure RFs is present in between 2 to 20 years of age. So this is the 2 lead ECG showing a right axis deviation with tall monomorphic RFs in the right side of precordial leaves with ST2 ST depression, TOF inversion. So there is a right ventricular hypertrophy with a strain pattern in the right precordial leads. In congenital rubella syndrome, associated with a PS, we'll have a superior axis. In Noonan syndrome, there can be extreme left axis deviation with broad splintered QRS. We'll come to the left sided heart. So in left heart, we have the aortic stenosis. The POFs are essentially normal unless complicated by significant mitral regurgitation. Usually the QRS axis is normal. There is presence of significant left ventricular hypertrophy denoted by tall RFs in the right precordial leaves with deep SOFs in the right precordial. Sorry, there will be tall RFs in the left precordial leads and deep SOFs in the right precordial leads. Right ventricular hypertrophy in aortic stenosis is present, especially in case of newborns who have a small LV cavity with presence of significant aortic stenosis and endocardial fibroelastotic changes in the LV. In Williams syndrome with supravalvular aortic stenosis with peripheral pulmonary stenosis, there can be right ventricular hypertrophy even in the presence of significant aortic stenosis. So this shows a normal axis with tall RFs in the V4, V5, V6 with ST depression and TOF inversion. showing a LV hypertrophy with a LV strain pattern. Coarctation of aorta will give rise to a pressure overload on the LV and a back pressure on the RV. In newborns and in infancy, it is characterized by right atrial enlargement and right axis deviation with presence of right ventricular hypertrophy. After infancy, coarctation of aorta will present with left ventricular hypertrophy. If it is associated with aortic stenosis, there can be ST depression. If it is associated with aortic regurgitation, there can be deep Q waves in the V5, V6, suggestive of left ventricular volume overload. Regurgitation in congenital pulmonary regurgitation, normal in mild to moderate cases. RV volume overload in severe cases. In congenital aortic regurgitation, there can be LV volume overload with Q waves in left precordial leads. Anomalous left coronary artery or the pulmonary artery is the condition in which the left system arises from the pulmonary artery, and there is presentation is usually after, say, around early infancy, say around 2 to 3 months of age, when the PA pressure starts falling and there is reversal of the blood flow in the left system. It's characterized by LV dilatation, presence of significant mitral regurgitation with LA dilatation. There is QRS axis is leftward, and there is presence of deep Q waves in left-sided leads like lead 1, AVL, V5, and V6. It can be more than 5 millimeter and more than 25% of the significant RFs. There can be T wave inversion and ST segment elevation in the precordial leads V4, V5, V6, suggestive of anterolateral ischemia pattern. Also, there is poor RF progression in the lateral chest leads. So this is a ECG over 3 months old, failure to thrive with congestive cardiac failure, diagnosed as a dilated cardiomyopathy with severe LV dysfunction and severe mitral regurgitation. What is characteristic in the ECG is there is actually presence of deep Q waves in lead 1, AVL, and V5 and V6. We'll come to the cyanotic heart disease. So it can be described as per the decreased pulmonary blood flow situation or the increased pulmonary blood flow situation. So cyanosis is the decreased pulmonary blood flow situation with the dominant RV. Usually it is present in tetralogy of Fallot or a DOD VSD PS or a single ventricle of RV morphology with a PS. Dominant LV is present in tricuspid atresia, Epstein's anomaly, or a single ventricle physiology of LV morphology. Cyanotic heart disease with the increased pulmonary blood flow situation, we have in the transposition physiology like a DTG or VSD without any pulmonary stenosis, or a DORV VSD without any pulmonary stenosis, or a Taussig ping anomaly without any PS. There can be admixture physiology like in a case of common atrium, truncus arteriosus, or a TAPVC. So tetralogy of Fallot. POs are usually normal. The duration of PO is narrow because of the underfilled LA. The QRS duration is same as in newborns. It's approximately 120 to 150 degree. And it does not change as the newborn matures because the demand of the RV do not change. Right ventricular hypertrophy with abnormal QRS like a counterclockwise loop is present in a case of DOV VSDPS or a TET canal like the AV septal defect with a top physiology. There will be presence of right ventricular hypertrophy characterized with tall monophasic RF in the V1. Early transition happens in lead V2 in the precordial leads. This is because of large VSD which faces the V2. Therefore, predominantly it actually attracts the left ventricular voltage. Presence and depth of Q waves will give an idea about the pulmonary blood flow and the LV filling. If there is a very severe pulmonary stenosis with trickle of anterogate flow and there is reduced pulmonary blood flow with underfilled LV, there will not be any Q waves. There will be a deep S pattern, so small R and deep S pattern in the precordial leads. So this is ECG with a patient of tetralogy of Fallot. There is a sinus rhythm, right axis deviation, right ventricular hypertrophy. As you can see over here, there is tall RFs in the V1, and then there is an early transition in the lead V2 and V3, which is quite characteristic of tetralogy of Fallot. Right bundle branch block pattern is present after this surgical repair. This is due to the delayed activation of the right ventricular aftertime due to disruption of the RV conduction system that happens during resection of the infradibular stenosis. If the QRS duration is more than 180 milliseconds, it is a very high risk for a development of ventricular tachycardia or sudden cardiac death. So that we routinely follow after a patient has a intracardiac repair. So this is the ECG of a patient post intracardiac repair. We can see the right bundle branch block pattern in the right precordial leads. Double-artery right ventricle with a VSD physiology without any pulmonary stenosis. The most characteristic feature is there will be left axis deviation in counterclockwise looping with presence of QFs in the lead 1 and AVL. Right ventricular hypertrophy will obligatory with tall RFs in V1, AVR, and deep SOF in the left precordial leads. Double-artery right ventricle VSD with pulmonary stenosis or presence of significant pulmonary arterial hypertension or pulmonary vascular obstructive disease will have right atrial enlargement and right axis deviation. Distinction from top here is presence of the counterclockwise looping in the DORB marked by slurred SOF in the inferior leads, that is 2, 3 and AVR, and broad RF in AVR, lead 1 and V5 and V6. Total anomalous pulmonary venous connection or TAPVC, the ECG will be characteristically resemble that of a ostium secundum ASD. There will be volume overload with pressure overload if there is a presence of significant pulmonary arterial hypertension, characterized by right atrial enlargement, right axis deviation, and right ventricular hypertrophy. In TGA, with an intact ventricular septum, there will be pressure and volume overload on the right ventricle. If there is a VSD, there will be pressure and volume overload on both the right ventricle and left ventricle according to the increased QP or the pulmonary blood flow situation. So typical feature is a right axis deviation with right ventricular hypertrophy or a biventricular hypertrophy. Any pattern can be possible depending upon the associated defects like a presence of a ventricular septal defect, ASD, or a PDA. In CCTG or a corrected transposition, the characteristic feature is that the RV is systemic, giving rise to the aorta, and the LV is subpulmonary. So the characteristic ECG findings are there is prolonged PR interval, leftward QRS deviation, presence of small Q wave in the right precordial leads, that is a V1 and V2, and absence of Q waves in the left precordial leads. Heart block, varying degrees of heart block are present, and 30% of the patient will have a complete heart block. This is due to a malalignment of the intraatrial and interventricular septum and anomalously located AV node. There will be reverse septal depolarization pattern already mentioned. So this is actually ECG sinus rhythm. As you can see, there is presence of Q waves in the right precordial leads in the V1 and absence of Q waves in V5, V6, which is normally present. This is a characteristic of a CCTG. Ebstein's anomaly, there will be P wave abnormality. There will be tall and wide P waves, also known as the Himalayan P waves. The PR is prolonged due to prolonged aberrant conduction. Short PR interval can be present if it is associated with the pre-excitation or a WBW syndrome. There will be inferior QRS axis. Left axis deviation can be present if there is a presence of a pre-excitation with deep Q waves in the inferior leads, that is lead 2, 3, and AVF. This is a ECG which is showing a short PR interval with a characteristic delta waves in the left-sided precordial leads suggestive of a right-sided accessory pathway in a patient with Ebstein's anomaly. Tricuspid atresia, there can be various types depending on the relationship of the great arteries. The characteristic feature is tall peaks P waves in lead 2. There can be biatrial enlargement. The most characteristic feature is absence of right ventricular leads or right ventricular dominance and presence of left ventricular hypertrophy in the precordial leads, characterized by deep SOF in the V1 and tall RFs in the V5, V6, and AVL. There will be counterclockwise looping with QFs in the 1 and AVL. So this is a patient with this is an ECG of a tricuspid atresia. You can see there is a left axis deviation on absence of RFs in the V1 and V2 and presence of characteristic LV dominance. Truncus arteriosus, there can be both volume and pressure overload on the ventricles. There can be biatrial enlargement. biventricular hypertrophy characterized by deep and equiphasic Q waves and tall R waves in the mid-precordial leads, like a Katz-Wurzel phenomena in a non-restrictive VST and PDA can be present. So this is the ECG from a patient with truncus arteriosus. There is right axis deviation, as you can see, and there is equiphasic large RS complexes in the whole precordial leads, suggestive of a Katz-Wurzel phenomenon. Hypoplastic left heart characterized by right ventricular hypertrophy and absence of LV forces. There is deep S waves in the V6. ST segment changes can be present if there is inadequate coronary perfusion from the retrograde flow through the hypoplastic arch. Basically, it's a duct-dependent systemic circulation. Single ventricle can have right ventricular hypertrophy or left ventricular hypertrophy. The characteristic feature is presence of stereotypic monomorphic URS morphology in all the precordial leads. And 90% of the patient of single ventricle or DILV or double intent left ventricle will have a LV morphology with an inverted outlet chamber. Single ventricle of morphologic RV, we have a right axis deviation with tall RFs in the precordial leads. So with this, we'll come to the differential diagnosis of a congenital heart disease based on ECG. So in acyanotic patients, if there is a large left to right shunt and the QRS axis is -32 plus 150 degree and presence of R' pattern, it is quite specific for ostium secundum ASD, present in more than 95% of the patients. If the QRS axis is -15 to -120 degree with right, left or biventricular hypertrophy, it can be present in case of a ostium primum ASD as a part of a AV septal defect. Normal axis with LV dominance or hypertrophy can be present in VSD, PDA or an AP window. Presence of right ventricular hypertrophy or biventricular hypertrophy can suggest development of significant pulmonary stenosis or pulmonary arterial hypertension. And any STD changes suggest ischemia. Obstructive lesions, right ventricular hypertrophy can be present in severe pulmonary stenosis or in case of Epstein's anomaly. Left ventricular hypertrophy can present in aortic stenosis or coarctation of aorta. Regurgitant lesions like significant aortic or mitral regurgitation, we have signs of left ventricular volume overload, and tricuspid and pulmonary regurgitation will have signs of right ventricular volume overload. In a cyanotic patient with cardiomegaly, with oligemic lung fills, with presence of pre-pulmonary and right axis deviation and right ventricular hypertrophy, this can be present in severe pulmonary stenosis with severe tricuspid regurgitation with a right to left shunt at the atrial level and presence of cyanosis. Right or biatrial hypertrophy with right bundle branch block pattern can be present in Epstein's anomaly, and WPW pattern with a negative delta with V1 is quite characteristic of Epstein's anomaly. Now, if we are dealing with a patient, cyanotic patient with the presence of ejection systolic murmur, and we think the patient is having a tetralogy physiology, in these cases, if there is a right axis deviation with right ventricular hypertrophy can be present in TOF or a DURV. Differentiating point is that a double-acted right ventricle or with a VSD will have an extreme right axis deviation, more than 150 degrees. It can be present in the TGA. Right axis deviation with left ventricular hypertrophy can be present if there is hypoplastic RV. Left axis deviation with left ventricular hypertrophy is quite characteristic of tricuspid atresia in a cyanotic patient. And left axis deviation with right ventricular hypertrophy is characteristic of an unbalanced AV septal defect. Single ventricle of RV or LV morphology and malposition, especially in the case of isomeric heart, can have all permutations and combinations. If you are dealing with a cyanotic patients with presence of congestive cardiac failure, like a TGA physiology or administered physiology, in those cases, if you are getting a right axis deviation or a right ventricular hypertrophy, it can be a TGA or a TAPVC or a DURV with a VSD physiology without any pulmonary stenosis or a truncus arteriosus. Right axis deviation with left ventricular hypertrophy is present in case of hypoplastic RV, the small RV. Left axis deviation with left ventricular hypertrophy is present in tricuspid atresia without any pulmonary stenosis. And left axis deviation with RVH is present in a case of unbalanced AV canal defect or in some cases of DURV VSD. And again, single ventricular malposition can have different permutation combination. Eisenmenger physiology. Right axis deviation with the right ventricular hypertrophy can be present in case of a BST, AST, PD, or an AP window. Left axis deviation with RVH present in a case of an AV septal defect. And left axis deviation with LVH can be present in tricuspid atresia. If there is a excess hysteria or pulmonary venous obstruction and we are getting a P-pulmonary, right axis deviation and right ventricular hypertrophy, this can be present in case of a obstructed TA-PVC or a hypoplastic left heart. A cyanotic patient with a normal clinical finding and a normal ECG, there can be some rare causes like a SVC, draining to left atrium, or a pulmonary AV fistula. So before evaluating the ECG, it is essential to know the age of the patient, presence or absence of cyanosis, and whether there is a presence of cardiomegaly or increase or a decreased pulmonary vasculature or pulmonary blood flow. So ECG should be taken into complication after denoting a proper history of the patient, thorough clinical examination, X-ray, and then we'll come to a ECG. So ECG is useful in a bedside diagnosis of a congenital heart disease. Thank you for your patient hearing.
Dr. Lopa?
Stop sharing.
After the excellent deliberation from Dr. Devobroto Nandi, I would like to invite Dr. Dhitobroto Das sir for his and his topic is how to read a pediatric ECG. Welcome, Dr. Dhitobroto Das sir.
Thank you so much. Can you see my screen and hear me?
Yeah, perfect.
Okay.
Continue.
Sorry for the technical difficulties initially. First of all, thanks to the West Bengal Academy of Pediatrics, especially Professor Kalpana Datta and Professor Shapan Roy for organizing this CME. And I will also basically thanks the young brigade of pediatric cardiologists now in Kolkata for taking the initiative to organize such a informative program. Now, my topic is relatively simple, and I would like to keep it simple to make it understandable to the most of the pediatricians to how to read the pediatric ECG. Now, as Dr. Shattoki was mentioning, that there are a lot of technical challenges when we are taking the pediatric ECG, starting from the patient, they are not cooperative. And often we still use the negative suction chest leads in many of the centers where it may be difficult to place such leads in a small way. Now, there are interpretation challenges also because of the many issues which we already have heard, that there is a switchover from the fetal to infant circulation. There is a gradual change from right ventricular dominance to the left ventricular dominance. And the heart rate also changes as the baby grows. All the durations also changes with time. It's not possible to keep a track of all these measurements, but one should have a overall idea how these changes happen. Now, while interpreting an ECG, the first things which we have read even if in our MBBS days also, that we should look at the rate, rhythm, axis, the different durations and intervals, and waveforms. Now, definitely, while looking at the ECG, not only the ECG, we have to take into consideration many other things, as Dr. Shattoki and Dr. Devobroto already pointed out. Number one is the age of the patient, because we know that the ECG changes according to the age of the patient, especially in the first 1 year of life, and then the clinical presentation. We cannot interpret any investigation without the clinical details of the patient. Then the quality of the graph, this is also very important. Often the quality of the ECG is not adequate to give a full report because the patient may not be cooperative, the patient was moving, all the leads are not adequate. The other point is the standardization. Whenever we are interpreting an ECG, we should be aware about the standardization. By standardization, I mean that what is the paper speed and the calibration. Now, before looking at the ECG, one should ensure that the paper speed is normal, that is 25 millimeter per second, and the calibration is 10 millimeter is equal to 1 millivolt. that because if there is a very high voltage ECG, then sometimes especially the calibration is changed, and if you are not aware about that change, then the interpretation will also be wrong. Now let us look at this ECG. So first of all, if you look at the ECG, you will get the details of the patient, that this is a 5-year-old child, and the paper speed and the calibration you can check from the ECG paper itself. And I think you know that how to check this one. Just let me come here. So if you look here, so this is the paper speed that is written as 25 millimeter per second. And you know the calibration is basically this one, where you see that the 1 millivolt voltage has been given, and that has given a spike of 10 millimeter. So before interpreting, one should ensure that the paper speed and the calibration are right. And then you look at the ECG itself. The first thing what I would look at is the rate. So you know how to calculate the rate. So as already mentioned by Dr. Shattuki in his speech, that the easiest way is to divide the number of 300 divided by the number of large square, or 1500 divided by the number of small square. So in pediatric patient, the heart rate is usually faster. So it is better to take the lower one, that is 1500 divided by the number of small squares, which will give an idea about the rate. Now, in this particular patient, the rate is about 90 beats per minute. Now, let us look at the same ECG. Someone has scanned the ECG and sent me by WhatsApp, which is quite common nowadays. So how to calculate the rate here? Because you don't see any square, neither the large or not the small. So is it not possible to calculate the rate here? Yes, it is possible. What is the length of an ECG normal strip? Whichever comes in the computerized ECG machine nowadays is 10 seconds. So if you count the number of QRS complexes in the whole strip and multiply it by 6, that will give you an idea about the heart rate. And here there are 15 QRS complexes in a length of 10-second ECG strip. So if you multiply that 15 into 6, that will give us the ventricular rate, which is 90 beats per minute. Often in the exam scenario, this is probably the easiest way, and the chance of mistake is less if you use this method. But again, the calculating the number of QRS complexes in case of tachycardia may be more time consuming. So you have to take your call that which method you will be using. Now, if we look at this ECGs, so the most prominent thing in both these ECGs is that there is significant sinus arrhythmia. So in case of sinus arrhythmia, if you are taking RR interval at when the RR interval is short, and if you are taking the RR interval where the RR interval is relatively prolonged due to sinus arrhythmia, the heart rate will also change. So in significant sinus arrhythmia also, it will be better to count the QRS complexes and multiply it by 6 to get a ventricular rate. Now, what is the normal rate? Again, as a pediatrician, we all know that will depend upon the patient status. This is taken from the Mimki Park. So this is the heart rate, usual heart rate in a patient at rest. But if a patient is active or the patient is crying, then the heart rate can go up significantly. And when the patient is sleeping, the heart rate can go down. So there is a wide range, and one should be very sure about commenting that this is abnormally high or abnormally low. Now, let us look at this single strip. So what do you think about the rhythm? What we have learned from previous speakers also, that in normal sinus rhythm, usually there is a QRS complex followed by every P wave. So in this ECG, which often we see in the monitors also, we are seeing that there is a P wave and which is followed by a normal looking QRS complexes. So can we say that this is normal sinus rhythm? For practical purpose, yes, but for theoretical purpose, no. Why I am mentioning that? Because we call rhythm sinus when it is coming from the P wave. It is coming from the sinus node and it is conducted normally to the ventricles. That means we have to ensure that the P wave axis is normal, which is 0 to 90 degree, and the PR interval is also normal. So if we don't have a 12 lead ECG or at least limb lead ECG, it is not possible to comment that whether the P wave axis is normal. So even if we are looking at the P wave morphology, which looks normal in this particular read, but if it is in a different lead, then it may not be a normal sinus P wave. So it is important to look at at least the limb lead ECG to get a correct interpretation of normal sinus rhythm. Now, after the rhythm, I will go to the axis. So this is as Dr. Shattoki was mentioning, that axis is basically the main vector of depolarization or repolarization. So it basically gives you an idea in which direction the ECG, the electrical wave or vector is moving. So normally we are looking at the QRS axis only, but it is also important to check the P axis and T axis to get a complete report. And for this, we use the interference triangle. We are very familiar with this ECG, this picture, that the normal QRS axis is usually between -30 to 90 degree. And if it is more towards the negative direction, then it is left axis deviation. And if it is more towards the right, then it is a right axis deviation. Again, the axis deviation will depend upon the age of the patient, as we already have discussed. Now, how to determine the axis? We all usually follow the first one, that we look at the lead 1 and the lead AVF. And if both the leads are positive, we know that the axis is normal because it is between 0 to 90 degree. But in some cases, it may not be possible to get a good lead 1, whether there may be equivocal results, like both the R wave and S wave are equal. So we are not sure whether the lead wave is positive or AVF is positive or negative. So we should know about the other methods also to get a rough idea. Like you can find out the limb lead where the R and S are almost equal. So axis will be perpendicular to that because the electrical vector is moving parallel to that, in perpendicular to that limb lead. So that will give a almost equal R and S waves. So we can get an idea from this that whether the direction of the electrical flux. Similarly, from the limb lead, the R and S wave will be the highest deflection when the axis is parallel to that. So that will also give us an idea about which direction the QRS axis is moving. About the chest and the limb leads, we know that lead 1, V5 and V6 usually are the lateral leads, and 2, 3 AVF is the inferior leads, and the V1 to V4 usually represent the anterior and septal leads. Again, if you look at this particular ECG, this is a ECG of a 10-year-old boy, and the calibration is normal. The paper speed, I assume that it is normal, so 25 millimeter per second. So if you look at the ECG, the lead 1 is positive and AVF is also positive. So it is a normal axis. The P wave morphology looks normal. It is positive in all the lead 1, 2, and 3. So the P wave is also in 1, and AVF P wave is also positive. So it is also in the normal axis. So it is a sinus rhythm. And the rate, you can calculate that there are 1, 2, 3, 4. So there are 10 QRS complexes. So heart rate is 60 per minute. So this is a normal sinus rhythm with a rate of 60 beats per minute. The QRS axis is normal, P axis is normal. So it looks like it is a normal sinus rhythm. Now, if we look at this particular ECG, do you think that this is a normal? So there is a P wave, but if you look at the lead 2, the long lead 2, the P wave is inverted. And if you look at the other inferior leads also like 3 and AVF, the P wave is inverted, which signifies that the P wave is basically moving from down to upward. So it is going away from the inferior leads. So this is an ECG which basically helps us to understand that the P wave is coming from non-sinus place. And this is known as the coronary sinus rhythm or the low atrial rhythm. Now, let us look at these two ECGs. So in one of the ECGs, you can see that the heart rate is about 50, and in another it is about 70. But one is abnormal and the other is the normal. So although the heart rate with 50 is in case of a 10-year-old child, it can be sinus bradycardia, and because all the P waves and the QRS complexes looks normal, and this is a normal sinus bradycardia in a 10-year-old child, whereas the other ECG, which shows a heart rate of around 70 beats per minute of a 10-day-old neonate, and you can see that the P waves and the QRS is completely unrelated and to the complete heart block. So the heart rate will again give you an idea about the patient's. The heart rate will basically depend upon the patient's age, and you need to ensure that the rhythm is normal. Although the heart rate may be in the normal range, but the rhythm may be completely abnormal. So after this, we'll go to the different waveforms and the intervals. So we all know about the usual ECG waves and the intervals, the P wave, the QRS complexes, the T waves, the common intervals like the PR interval and the ST segment changes. So let me start with the P wave. So this is best seen in lead 2 and lead V1. The P wave axis is usually same as the QRS axis, that is between 0 to 90 degree. And the duration is usually between 80 to 100 milliseconds. The P wave amplitude does not change significantly throughout the childhood. So P wave amplitude is roughly about 2.5 to 3 millimeter, and if it remains more or less same throughout the childhood. So the P wave is basically the atrial depolarization. So if there is some atrial changes, that will alter the P wave morphology. If the P wave is tall and peaked, as is called is P pulmonal, so that suggests right atrial enlargement. Whereas if the P wave duration is prolonged and there is a biphagic or notched P wave, that is called P mitral, which suggests that there is a left atrial enlargement. One thing is very important is that in pediatric patients, often you can find a notched P wave with a normal P wave duration. So that may be a normal variation also, and found in almost 25% of pediatric issues. Let us come to the QRS complex. QRS axis is the direction of the mean vector, as we discussed. The axis varies with age. So in the newborn period, the mean axis is about 125 degree, whereas in the adult, it is about 50 degree. So there is a gradual change from the right axis to the left axis in the first few months of life. The QRS duration usually is increases with age, and in the premature baby it can be 40 millisecond, whereas in the adult it is about 80 to 90 millisecond. More or less in the pediatric age group, we consider that the more than 100 millisecond of QRS duration we consider it as abnormal, whereas in adult, if it is more than 120 millisecond, we consider the QRS is prolonged. Again, the QRS amplitude will vary according to the ECG lead and the age of the patient. The QRS waveform that we know that Q wave is basically the first negative deflection of the QRS complex. So it is the first negative deflection, and it represents the depolarization of the interventricular septum. Whereas the R wave is the first positive deflection, and it is the depolarization of the ventricular mass, and most of the time it is the most prominent wave. S wave is the negative deflection just after the R wave, and it basically represents the depolarization of Purkinje fibers. R prime and S prime is the positive and negative deflection after the S and the R prime waves. So accordingly, the QRS waveforms can be named differently. So I'm not going into the details, but the most prominent deflection is usually referred in capital letters, and if the other deflection is less than 50% of the positive deflection or the maximum deflection, then they are represented by the smaller letters. The QRS voltage abnormality, again, if in case of ventricular hypertrophy, there will be high voltages. Whereas in pericardial effusion or myocarditis, the QRS voltage will be low. The voltage criteria Devabroto has already discussed in detail. The QRS duration abnormality also is very important. Normally, as I mentioned, more than 80 millisecond, or in older children, probably we will take it as 100 millisecond as normal cutoff. It indicates that the prolonged time is taken for the ventricle for depolarization, and which is also known as the ventricular conduction disturbance. Dilated and hypertrophic ventricles or defect in the conduction system can cause prolonged QRS, usually with abnormal QRS wave morphology. The T wave represents the ventricular repolarization, and this is the QRS. This is the ECG wave, which usually represents the anteroposterior direction, because the T wave axis, the normal in the horizontal or the axial plane, is between 0 to 90 degree. But what is important is the horizontal plane, it is anterior in adults. So in V1 and V2, we see positive deflection in T wave that represents the electrical vector, while repolarization is moving from posterior to anterior. But in case of smaller children, or in the most of the pediatric age group, the T wave is usually negative in V1, V2, which represents that it is moving in the opposite direction. In the first few days of life, in first 2 or 3 days, the T wave is positive, like in the adult. We should keep that in mind when we are interpreting an ECG of a neonate. Among the intervals, PR interval, it is very important, and it represents it is the time required for atrial depolarization to reach the ventricle after the delay at the AV node. The normal PR interval varies with age, and usually it is between 80 to 160 milliseconds. The PR interval is prolonged in several conditions: the first-degree heart block, in myocarditis, hyperkalemia, drug toxicity like digitalis and quinidine. The PR interval may be shortened in WPW syndrome, in glycogen storage disease, and if there is an ectopic atrial pacemaker. And there may be variable PR interval also, like in wandering pacemaker or second-degree heart block. So all these abnormalities will be taken up in subsequent talks as the whole program is planned. So I'm not going into the details. What is important in QT interval, we are very much touchy about QT interval, because this is a condition which can cause sudden death. And we know how to calculate QT with the Bazzett's formula, the QT divided by the square root, the RR interval. What is important to keep in mind while calculating this corrected QT is that RR interval should be in seconds only, should not be taken in milliseconds, because that will give a completely wrong result. So usually less than 450 is considered as normal in male and less than 470 in female. These numbers vary from one study to another. So minor changes is in that these values should not be considered very significant. But if there is a significant change, we should be worried about that. And as already pointed out by the previous speaker, Professor Saxena, that if the T wave is more towards the next QRS complex, so then it is more likely to be a long QT syndrome, and it can be a congenital or drug effect. What is important that while measuring QT, it is very important to know how to calculate the QT, where to take the Q and where to take the T, so that we should not make any mistake. That it should be the intersection of the T wave maximum slope with the isoelectric line. So what is the isoelectric line? When the heart is completely repolarized and the depolarization has not started. So that is the TP interval. So TP interval or even the PR interval can be taken as the isoelectric line. And as shown in this particular picture, you can see that you have to take the intersection of the isoelectric line with the maximum slope of the T wave to get the ending of the QT interval. So it is very important to correct the QT interval correctly, so that we do not make any mistake, because a slight mistake in the measurement can change the ultimate value significantly. These are the two ECGs with a prolonged QT. ST segment is the horizontal and it is isoelectric usually, and there is we have to compare the ST segment with the isoelectric baseline to understand whether it is elevated or depressed. Minor change may be normal in some cases. So up to 1 millimeter shift in the limb leads and 2 millimeter in the left precordial leads are considered normal. Now, if you look at this ECG, you know that all the QRS and the ECG complexes are low voltage. So these kind of ECGs are very common in myocarditis, and you can see that the T waves are inverted in all the precordial leads. And if you look at this, this is another ECG where you can see that there is a widespread ST depression, and the T wave is there is widespread ST depression here, and this is basically a grossly hypokalemic patient. Potassium came out to be 1.6. So sometimes the ECG will give you a clue to the electrolyte abnormalities as well, and I think that will be discussed in subsequent lectures as well. Now, this is a 2-year-old child, and what we commonly term as is the incomplete right bundle branch block. There is a RSR- pattern in the V1 leads, but it is better not to use this term, especially in pediatric population, because this is often seen as a normal variation, and we should not unnecessarily cause worry to the parents. So this is the ECG I started with. Again, it is very important, and this is the last ECG I'm going to show. That is very important for the pediatrician to know what is normal and what is abnormal. If it is not possible, it may not be possible for a pediatrician, even sometimes the pediatric cardiologist also argue about the final diagnosis of a particular ECG, but it is very important to identify that which is normal and which is abnormal. Like the ECG I started with, that we have seen that it looks like more or less normal, but there is some anterolateral ST elevation, minor elevation, and there is an upslope of the ST segment in the anterolateral leads. So whether and often when we are looking at the ECG, the computer interpretation also, the pediatricians often get panicked whether it is abnormal or normal. So this is called as early repolarization, which is a benign condition. So we should not worry about these minor changes, and these early repolarization abnormalities are often found in the normal persons as well. These are the normal values in pediatric electrogram. This one should keep as a reference and look at any of the textbooks or internet when you are not sure whether any interval or the voltage criteria is fitting with the normalcy. So to take home message, that what is important, that age and clinical presentation of patient, we should check the calibration and the quality of the ECG. One should take a systematic approach and go by the methods we already described to try to find out major deviations. Minor deviations are often normal, so one should not worry about that. And if there is any doubt, check the normal values for age and sex. Thank you so much.
Lopamudra.
Yes. So after the very lucid and enlightening talk regarding how to read pediatric ECG, we would like to invite Dr. Debashree Gangopadhyay for our penultimate talk of the day on the common X-ray changes in the congenital heart disease. Dr. Debashree Gangopadhyay, after doing her MD pediatrics, has done fellowship FNB in pediatric cardiology from India, and then followed by pediatric cardiology fellowship from Australia. Now she is acting as the head of the prestigious Institute of R.N. Tagore Hospital in pediatric cardiology. We'd like to invite Dr. Debashree Gangopadhyay.
Thank you for the kind introduction. Shall I start?
Please, please.
Am I audible?
Yeah, you are audible and slides are visible also.
Okay, yeah, I'll just turn on my camera. For some reason, my camera is not getting turned on, but that should not worry. Very good evening to all the respected chairpersons and the audience. So I'm going to talk on interpretation of chest X-rays in congenital heart diseases. Yeah. So as we all know that X-ray is a widely available clinical tool, and a proper X-ray gives a very important clinical information about the structures studied. Often it is the first screening tool for suspected cardiopulmonary diseases. Before reading a chest X-ray, one should check the patient's name first, identification number, and if there is any number given by the radiologist, then check the date on which the X-ray is taken and the side markings, left for left and R for right. Just a moment, I'll just. Okay. Now, the different views that we commonly use in clinical practice in pediatrics is PA view. That is when the patient faces the film. This view is most widely used. And another view that is used very commonly, especially in cardiology and post-operative cardiology, is AP view. That is used after operation or in ventilated or otherwise immobile patients. Lateral view is sometimes necessary, but it is rarely used in everyday clinical practice. Now, in the PA view, while recording a PA view, patient faces the film with chin up, shoulders rotated forward to displace the scapulae from the lung fields, and exposure is made in full inspiration. And the X-ray beam should center around T4 and T5. In the AP projection, the film is kept at the back of the patient and the scapulae overlie the lung fields. So that is a disadvantage of AP view. Clavicles project more cranially and the disc space of lower cervical spine is seen more clearly. And another thing we should keep in mind is heart size appears bigger in AP view than in PA view. Now, we should also know how to assess adequacy of a film. So the lung fields, in an adequately taken chest X-ray, the lung field should be visible from apices down to the lateral costophrenic angles. And there should not be any superimposition of chin over any structures, or the scapular border should also not obscure the lung fields. Centering, meaning that a well-centered film, in a well-centered film, the medial ends of clavicle are equidistant from the vertebral spinous process at the level of T4 and 5. And the X-ray film should be as minimally rotated as possible. But it is not always possible to use this minimal rotation thing in very small babies. This is how a correct angulation should look like. So the clavicle should lay over third rib as shown by the broad arrow. Adequate penetration means that the vertebral bodies and the disc spaces should just be visible down to the T4 and T5 and not beyond. We should be able to see the ribs through the heart, and there should be clearly visible pulmonary vessels nearly to the edges of the lung. When we call it an adequate X-ray, it should be an inspiratory film. By that we mean minimum 9 posterior ribs should be visible, and anterior end of fifth or sixth rib meeting the middle of the right diaphragm should be visualized. Now on the left-hand side, we see inspiratory film where the 9 posterior ribs, 8th posterior rib can be seen down up to here. This is the 8th rib, shadow of the 8th rib, and this is the 6th rib from the anterior side. And this is an expiratory film, and in an expiratory film, the heart looks more globular. So there is a false cardiomegaly on an expiratory film. Coming to the assessment of the cardiac shadow. So this is a pictorial diagram of what the right and left heart border is made of. The right heart border from above downwards is made of superior vena cava, right atrium, and inferior vena cava. And on the left-hand side, from above downwards, aorta is the topmost structure, then comes the main pulmonary artery, then the left atrial appendage, and finally left ventricle. So these are the structures which form the both the borders of the heart. And if we remember which structure forms where, we should be able to identify when there is any abnormality of any of the structures mentioned. Coming to assessment of cardiothoracic ratio or assessment of cardiac size from chest X-ray. So cardiac size is assessed by dividing the largest transverse diameter of the heart by the largest transverse thoracic diameter. So the largest transverse diameter of heart is taken as it is shown in the picture. And the largest thoracic diameter is taken from here. And it is the normal value is around 50%. So the heart shadow should occupy 50% of the thorax. It can be 55 or up to 60% in a neonate or an infant. In the lung fields, we see pulmonary artery shadows cast by pulmonary artery, pulmonary veins, and pulmonary artery cast a shadow which looks like reticular vascular shadow. And the pulmonary venous shadow is seen like a low density, woolly, fuzzy opacity. Other structures like alveoli, pleura, interstitial, the lymphatics, interstitial lymphatics are rarely visualized unless they are abnormal. It is normal to have a paucity of vessels in the outer third of the lungs. So this is an X-ray which demonstrates normal lung vascularity. Here, what we see is there is a gradual tapering of vessels towards the periphery, and the lower lung vascularity is more prominent compared to the upper lung. There is symmetry in vascularity of both lungs, and the right descending pulmonary artery size is roughly similar to trachea. So once we have known what is normal pulmonary vascularity, we should ask what is oligemia, what is pulmonary oligemia. So in pulmonary oligemia, vascular shadows are reduced in number and extent, and they are all main pulmonary artery and branches. So the hilar pulmonary arteries and the peripheral pulmonary arteries all are reduced in caliber, and they are not even seen in the intermediate lung zones. So the causes of pulmonary oligemia, as we find in our everyday clinical practice, are right to left shunts, right heart failure, pericardial effusion, constrictive pericarditis, and rarely pulmonary embolism in pediatric age group. So this is an example of pulmonary oligemia. What is pulmonary plethora? Plethora meaning excessive flow of blood through the lung vessels. So there is dilatation of hilar pulmonary vessels, and peripheral lung vasculatures are traceable up to lateral 1/3 of lung fields. As we have seen in the previous slides that in the normal vascularity, the lateral 1/3 of the lung field should be less vascular, or even vessels should not be traceable up to that segment. The right descending pulmonary artery is bigger than trachea. Peripheral vessels, the shadow that they cast is bigger than the adjacent end-on bronchi. And the end-on vessels are numerous. It is generally more than 5 per lung field. The causes of pulmonary plethora are large left to right shunt lesions. There can be few cyanotic congenital heart diseases, and so on. So this is a chest X-ray which documents cardiomegaly with pulmonary plethora. Now, how to identify chamber enlargement? This slide demonstrates right atrial enlargement. So the right atrium is called enlarged when the right heart border extends beyond the medial 1/3 of the lung field. So if we arbitrarily divide the lung by 2 vertical lines, then the lung fields will be medial, intermediate, and lateral. Now, if the right heart border crosses beyond the medial lung field, we call there is right atrial enlargement. The other way of knowing it is if the right atrium goes more than 50% of this vertical distance between the medial end of clavicle and upper border of right diaphragm. So if the right atrial shadow extends more than 50% of this distance, then we call it right atrial enlargement. Now, left atrial enlargement, there are several features of left atrial enlargement. Earliest could be the left atrium can enlarge in superior direction. It can enlarge posteriorly. It can enlarge to the left side. So the signs that we often see on chest X-ray is double contour on the right border of the heart. Initially, when the left atrium is smaller than right atrium, the inside shadow is cast by the left atrium. But as the left atrial size gradually goes on increasing, the right and left heart border superimposes. At that time, this double contour is absent. And even when it is progresses further, the left atrium goes beyond the right atrial margin. Now, there is widening of the carinal angle. Normal carinal angle is 90 degrees. And when the left atrium elevates the left bronchus, left main bronchus, the carinal angle is elevated beyond 90 degrees. With further increase in the left atrial size, there is enlargement in the left atrial appendage, which causes initially it becomes more prominent, and then it causes a convexity on the left border of the heart. Now, right ventricular enlargement is typical. It can produce very different contours on the chest X-ray, but the hallmark of right ventricular enlargement is rounded and elevated cardiac apex. Now, this hallmark feature is found only in very few conditions like tetralogy of Fallot or tetralogy of Fallot with pulmonary atresia and truncus arteriosus. And typically, this rounded and elevated cardiac apex is not seen in other conditions where right ventricle is known to be hypertrophied, like in atrial septal defect, pulmonary arterial hypertension, valvular pulmonary stenosis, or Epstein malformation. I'll give the illustrations in subsequent slides. So this is a typical example of right ventricular enlargement where we see the apex is elevated, and it's an example of boot-shaped heart. Now, this is an example where we expect, this is a case of pulmonary arterial hypertension, where we see the prominent MPA segment on the left heart border, yet the cardiac apex does not look anywhere elevated or rotated upwards. So it's an example where even though clinical right ventricular hypertrophy is there, but the X-ray does not give you an RV type of apex. The left ventricular enlargement is shown on X-ray by elongation of the left heart border, and with leftward and downward displacement of the cardiac apex. Now, this when left ventricle is enlarged, the cardiac apex can be seen below the diaphragmatic contour through the gastric air bubble. And on lateral view, the left LV is seen encroaching on the retrocardiac pre-spinal clear space. Now, this is an example of left ventricular enlargement where you see the straightening of left heart border and the cardiac apex is shifted down and out, as it is typical for left ventricular enlargement. Now, I'll give a few clinical illustrations of different kind of chest X-ray in various clinical settings. Now, we all know the left to right shunt lesions can be pre-tricuspid or post-tricuspid. Chest X-ray will reflect the hemodynamic state as the X-ray picture depends on pre or whether the shunt is pre or post-tricuspid in nature, what is the amount of the shunt, and presence of pulmonary arterial hypertension. Now, this is a case, this is a chest X-ray which shows cardiomegaly with increased pulmonary vascularity. As you see, the right descending pulmonary artery is almost like it is bigger than trachea, and there is the pulmonary vasculature overall is increased. It is a case of atrial septal defect, a grown-up child with atrial septal defect. Now, this is another chest X-ray in a smaller child with a very large atrial septal defect. What we see here is a huge cardiomegaly, and the lung field is characterized by pulmonary plethora. So the lung vascularity overall is very much increased. So here we found an unnatural condition of associated pulmonary arterial hypertension in case of an atrial septal defect in a small child. Now, on this PA view, what we find is there is mild cardiomegaly, and the hilar pulmonary artery, as we find on the right side, hilar pulmonary artery is dilated. But if we compare the hilar pulmonary artery with the with its first lower lobar branch, we will see that there is abrupt cutoff in the vessel size, and we call it peripheral pruning. So this was a case of atrial septal defect with very severe pulmonary arterial hypertension. In other words, it's called Eisenmenger ASD. This is a chest X-ray which shows significant cardiomegaly and pulmonary plethora, as it is characterized by increased density in the middle segment of the lung, and the pulmonary vasculature is traceable almost up to the lateral 1/3, and the same bilaterally. So, and if you notice carefully, you'll see a thymus also. It is prominent on this side, on the right upper border. So this was a case of AV septal defect with severe AV valve regurgitation. Next one is a 3-year-old boy with large ventricular septal defect with large shunt characterized by cardiomegaly with LV type of apex, which is down and out, and very prominent pulmonary, central pulmonary artery vessels. So in other words, there is pulmonary plethora. So it's a large VSD with significant left to right shunt and significant hyperkinetic pulmonary arterial hypertension. This is a chest X-ray which shows mild cardiomegaly. And characteristically, if you see in the hilar area, the pulmonary arteries are quite prominent, while in the pulmonary arteries are just reduced in caliber immediately after in the middle zone of the lung. So it's a case of large, and also on the right heart border, you see that there is a prominence of the main pulmonary artery segment. So this is a case of VSD with severe pulmonary arterial hypertension. Now this is a very characteristic X-ray of cardiomegaly with left ventricular enlargement. On the right side, you see double contour, so there is left atrial enlargement. This shadow is cast by dilated ascending aorta, and on the lung fields, you see pulmonary plethora. This was a case of significant left to right shunt through a PDA. Now, this is an interesting case. There is cardiomegaly with LV type of apex, and there is very prominent main pulmonary artery segment. But what is striking on this chest X-ray is there is differential lung vascularity. On the right side, the lungs look black and on more translucent, and on the left side, vascularity appears plethoric. So this was a case of PDA with absent right pulmonary artery. So the lung did not have a right lung did not have a connection with the main pulmonary artery. It was supplied by collaterals, abnormal vessels. So there's a list of cyanotic congenital heart disease. It is broadly classified in the under the headings of decreased pulmonary blood flow, which is TOF physiology or Epstein's anomaly. It can be increased pulmonary blood flow, as in TGA physiology, TAPVC, and truncus, and it can be pulmonary venous hypertension, like in obstructed TAPVC or hypoplastic left heart syndrome. Now, this is a chest X-ray which I have shown in my previous slides also. This is a classical example of boot-shaped heart with pulmonary oligemia, a case of tetralogy of Fallot. Now, this is yet another example of tetralogy of Fallot. Here also the right ventricular type of apex is visible, but one thing which is striking is pulmonary plethora. So in tetralogy of Fallot, it is not always compulsory to have a very reduced pulmonary flow. This case had a lot of abnormal vessels going through the lungs, so the pulmonary vascularity was actually increased. This is a case of tetralogy of Fallot with absent pulmonary valve, which is shown by very dilated branch pulmonary arteries, which is seen on both right and left hilum, and there is characteristic right ventricular type of apex. This is a patient with right ventricular type, boot-shaped heart with right ventricular type of apex. If you look carefully on the right side of the trachea, there is an indentation, and it is because of the right-sided aortic arch. So this is a case of tetralogy of Fallot with the right-sided aortic arch with pulmonary atresia, which is characterized by concave pulmonary area. So the pulmonary artery is absent from here. This is a case of another cyanotic heart disease with less pulmonary blood flow, characterized by LV type of apex and a prominent ascending aorta. This is this X-ray is a postoperative X-ray, which is I'm saying because there is there are these sternal rings which is seen in the midline. So this is seen after sternotomy. So this was a case of tricuspid atresia and pulmonary stenosis, and this child had a cardiac surgery. Now, this is a newborn X-ray with a huge cardiomegaly. This is characteristically seen in cases of newborn who present Epstein anomaly who present in the newborn period. And if you look at the pulmonary lung fields, the lung fields are characteristically very translucent. So the lung pulmonary blood flow is less, oligemic lung. This is an example of a grown-up child with cardiomegaly. Characteristically, there is right atrial enlargement and an apex which is which is shifted down and out, and the pedicle is narrow and the pulmonary vascularity is less. So this is a grown-up child with Epstein anomaly. This is a classic example of Egon side. Now there are a few very famous acronyms in congenital heart disease chest X-ray. This is one of them. Egon side, the moment you see this kind of X-ray, one thing that strikes the mind is it's a case of TGA. In a newborn, it's a case of TGA with intact septum, and the lung blood flow is high. So this is a classical example where right ventricle is enlarged, right atrium is enlarged, and the vascular pedicle of the heart is narrow. This is an example of huge cardiomegaly in a 5-year-old child. This is a complex cyanotic heart disease which got Eisenmengered. There is enlargement. The cardiac apex looks like it's an RV type of apex. There is both biatrial enlargement, double contour on this side, and the upper lobe vascular prominence. So there is pulmonary venous hypertension, and the hilar pulmonary arteries are prominent. So it's a case of Eisenmenger syndrome in a cyanotic heart disease with both pulmonary arterial and venous hypertension. This is an example of the very typical chest X-ray of a patient with CTGA. Why I'm saying is there is a prominent aortic knob on the left side, which is normally not seen. So it is found in 50% of cases of CTGA, and there is cardiomegaly. This is also another very typical example of what we call snowman appearance. In a snowman appearance in congenital heart disease is a grown-up child with supracardiac TAPVC. Now the right side of the snowman, this is also, in other words, it's called figure of 8. So imagine this is one limb of 8 and the other limb is below. So one side is found by dilated superior vena cava, and the other side is found by, the left hand side is found by dilated abnormal vertical vein, which is taking the pulmonary venous flow to the superior vena cava. There is right ventricular type of apex, right atrial enlargement, and increased pulmonary vascularity. This is an example of a newborn with a huge cardiomegaly and pulmonary plethora. Although the diagnosis is not very characteristic from this X-ray, but this was a case of truncus arteriosus. This is a very characteristic chest X-ray in a newborn with ground glass appearance of lung fields, not much of cardiomegaly, and there is the lung is hyperinflated. This was a case of obstructed infracardiac total anomalous pulmonary venous connection. This is a case where the 3-month-old baby, where we found where there's a huge cardiomegaly, left ventricle is enlarged, apex is down and out. There is collapse of left lower zone. There is upper lobe vascular prominence, which says that there is pulmonary venous hypertension. The pulmonary hilar PAs are also quite enlarged. So, and this was retrospectively on echo, we found that there was anomalous left coronary artery, also called Al-Kappa. This is a case of huge cardiomegaly because of severe congenital mitral valve regurgitation. Mitral valve regurgitation in both congenital and acquired condition causes enlargement of left atrium and left ventricle. Here the left ventricle is enlarged and left atrium is enlarged because you see the left heart border is convex. So the left atrial appendage has enlarged, and there is upper lobe vascular prominence. So pulmonary venous hypertension. So it's a case of pulmonary venous hypertension and arterial hypertension because of severe congenital mitral regurgitation. This is an example of chest X-ray, where there comes the importance of noting the right and left side as marked by the radiologist who took the film. So the apex is on the right side. Unless the right is marked, you will find that the film is rotated and you may hold it the other way. But actually, this was a case of dextrocardia, and there is midline lever. So it was a case of situs ambiguous dextrocardia. This is an example of situs inversus dextrocardia, where the liver has come on the left side and stomach gas bubble. Stomach bubble is found on the right side, and the cardiac apex is rotated towards right. This is an example of globular heart. It is because of severe pericardial effusion leading to near cardiac tamponade, and so this is another cause of cardiomegaly. So this brings me to the end of my presentation. So to conclude, extra plate should be interpreted at the bedside of the patient, and proper projection, exposure, and centering is necessary for correct interpretation. I thank you all for your patient hearing.
Thank you, Devasri, for your excellent presentation. So over to you, Lopa, to conclude today's program.
Thank you, sir. If I can take the privilege of saying that you were the one who inducted me with chest X-ray back in ICH. How can I forget that? You and Dr. Shukanta Bhattacharya, you two were stalwarts with chest X-ray, and you were always ready to give us explanation about how it should be interpreted. My heartfelt thanks to you, sir.
Welcome, and this is my pleasure to listen to you throughout the session, and I was glued to my chair listening you. Anyway, Lopa, please conclude today's session. I think Lopa is not there, so I would request all of you to answer the questions in the chat box, and if the questions are not answered, you may write it in that particular WhatsApp group, and I request all the speakers to give a handout in the PDF format so that we can share with the attendees. This is my honest request. You can give the handouts, so they will be helpful for them. So tomorrow again, we will come at 6 p.m. sharp, and should we conclude the day? Professor Datta?
Yes. Very big thank you to all the speakers. They've done their job very meticulously, and a wonderful presentation by all. And I think the participants have learned a lot, and there's no ending of learning. They will go on learning throughout life, but they have learned a lot from today's presentations, and we have coming 2 days, and lots of time will be there to interact. And as we are having another meeting at 8:30, I think, so we must conclude over here. Thank you all the participants, all the faculties, moderators, conveners,